Hi, everyone. It's Dr. Sheftal again with Truth in Science. And we have part 3 today with Dr. Jay Bhattacharya. So good afternoon, Jay. How are you?
Good afternoon, Reed.
It's going to be a very interesting day. We're going to talk about herd immunity and the vaccines today. So we'll get into a lot of things that people are interested in. So let's go ahead. Oops, let me make sure this changes. Okay, did your screen change, Jay?
Yes.
Okay, great. So this is my bona fides page, which we'll skip as usual. I have a funny story about this. At first, I didn't do this at all. And a couple of people watched my videos and said, you've absolutely got to put your credentials on there, or your background anyway. So I started doing it. Jay, did your screen change again?
Yes.
Okay, let me know if something doesn't change. I've got a funny story about Jay. I want to tell it now. The reason I'm asking Jay if the screen has changed is the first 2 parts that we made, Jay was looking at something different than me the whole time because I set it up wrong. And I like this story because it really tells you who Jay is as a person. He's so humble and kind that he didn't tell me that I was messing it up. And for about 30 slides, he was able to take part in the conversation beautifully without even looking at the slides. And that speaks to his intelligence. So that's sort of the 2 aspects of who he is that really impressed me a lot. And Jay, it's really been an honor to get to know you. I just wanted to tell you that.
My honor as well, Reed.
Thank you very much. But so here are Jay's credentials, which are spectacular. And I know Jay's the type of person that doesn't really, he cares about his credentials, I'm sure, but he doesn't make a big show of it or anything. But with all the invective that's been going around everywhere, I'm awfully glad that yourself, Dr. Kulldorff, and Dr. Sunetra Gupta do have the credentials that you have. And do you agree that that's part of the problem, is that when you guys came on and made this Great Barrington Declaration, it kind of legitimized a different way of looking at it, and it made people who had been maybe hesitant to speak up more open to expressing their true feelings. You sort of see what I mean?
I mean, I think a lot of the problem has been credentialism. Like, so a lot of, in fact, the narrative around lockdowns and COVID policy in the early days was, well, the science says you must do the lockdown, and a lot of that was based on people like Dr. Fauci's credentials. It was an argument from authority as opposed to an argument from reason.
Right.
I mean, part of the problem that the Great Barrington Declaration posed to someone like Dr. Fauci or Dr. Collins, who was the head of the National Institute of Health, was that now you had people with credentials who were saying, look, this is not a good idea. Martin Kulldorff, who's from Harvard, was then from Harvard, and then Sunetra Gupta was probably the world's best epidemiologist. She's at Oxford. And so it was really hard to dismiss, although they Francis Collins wrote an email to Tony Fauci calling us fringe epidemiologists, because we just posed a political problem to them. Like, they couldn't just dismiss us out of hand. And instead of trying to argue with us on the basis of actual facts, they went to credentials.
Yeah, I've got that actual email in the presentation if we get to it today. Certainly, if we don't today, we'll get to it next time. But yeah, I've got the whole series of what happened there on slides, his email, the responses, and so forth. It's just amazing. It blows my mind every time I look at that. It's almost unbelievable that someone like Francis Collins would make an email like that. But he did, and that's where we are. So let's proceed and see if we can get to it today. We certainly are going to get to a lot of talk about censorship and so forth, and that's part of it. Actually, that slide is in that section. So let's go ahead now. I put this picture in, Jay, because I like it. It's a very, very nice picture of you.
Much younger than me. A younger
is
version.
It really? Okay.
I think it's like, I don't know, 2010, 14 or 13.
Oh, okay.
I don't know. I don't know when it was.
Yeah. No problem. I'm sure I have the same issue going on. We've already done all four of these, so I'll skip this one to talk about what we're going to do today. It's going to start with herd immunity after we go over a few clarifications from last time, and then we're heavy into the vaccine. So I won't read everything that we're going to go, just in the interest of time. And finally, here's the section where I show Dr. Collins's email and a lot of other things. That's chapter 12. And then we're going to finish up with rapid fire questions with you, Dr. Bhattacharya. So let's clarify a few things. There were a few private messages I got. I wish people would make comments in the comments section so everybody can benefit from it. But I did get a couple of questions about asymptomatic spread. And a lot of the people were confusing asymptomatic patients with pre-symptomatic. Which I can understand why they would do that, because neither has symptoms yet. There's certainly no claim whatsoever that pre-symptomatic people would not be able to spread the virus. Asymptomatic, however, there's a little bit of reasoning you can make on both sides of this argument. I think, Jay, you mentioned the study you had seen, right? That showed that there was asymptomatic spread.
Yeah, but it's rare. So this was a study by Madewell and colleagues. I think Zachary Madewell. It was published in the Journal of the American Medical Association. In fact, I think they published an update. So in the original study, published I think in January 2021, they reported that asymptomatic spread. They looked at spread within a household. So somebody, for whatever reason, was found to have PCR positive or something, but no symptoms. And they looked what fraction of the time did somebody in that situation spread it to somebody living in the same household with them. And it was the number was 0.7%.
Okay, so less than 1%.
Now they did an updated version of that study, which I've learned about since we last talked. There, what they did is they distinguished pre-symptomatic from asymptomatic spread.
Yes.
And pre-symptomatic as you might expect is more likely to spread, but it's still like 3%. Only 3% of the time that someone's pre-symptomatic, or maybe 3.9, I forget the exact number, that they, like 4 out of 100, 3 out of 100, they spread it to somebody living in the same household as them.
Yeah, I have a little bit of, excuse me, go ahead, Jay, sorry.
I mean, it's pretty rare is the point.
Yeah, that is the point, because the problem, which I'll show in one slide or two from here, is that they use this concept of asymptomatic spread to justify testing everyone, which I think was a horrible idea. It took the policymakers into a very dark place as far as making policy. They based them all on cases, and they made some crazy policies because of it, because the cases would take off and be enormous after the cases and deaths had followed each other very nicely. And when they started testing everyone, the cases went through the roof and the deaths kept going down. So they started making policies that didn't make any sense. I'll show you that graph in just a second. Now, the reason I brought this up is because remember the 7 steps necessary for a pandemic to occur. In order to be able to transmit this from one person to another, which is spread, okay, you need a large viral load. And that's the whole basis for why the furin cleavage site was put into it, because that increases fusion and increases the viral load, okay? Now, I didn't think that asymptomatic spread was possible, just from pure logic. Now, I haven't looked at any studies. I was just thinking about it. And, you need a lot more symptoms to spread. You need a lot more virus to spread than you do to have symptoms. Okay. So that makes me think that spread isn't possible unless you're going to have symptoms at some point because of your viral load. And so that's what bothered me about it. And when you start thinking of examples of other viruses, like hantavirus, or even what happened in Mojang. You've heard that story in 2012, Jay. Do you remember this? 6 miners who were cleaning guano got very sick and went to the hospital, and 3 of them died. And that's connected to SARS-2, I think. That's speculation, though. I could talk about that some other time if you want to. But all these people had horrible symptoms. You know, people that get hantavirus can die and do very frequently. And the 3 of the 6 Mojang miners died, but none of those people that I'm talking about in those 2 viruses spread it to anyone else, even though they had horrible symptoms. So when you talk about I think asymptomatic person spreading, it's a big stretch for me.
I mean, I think that the thing is about this virus, it's much more infectious than some of these other viruses. Like, it's certainly more infectious than SARS-1. And I think it's because it spreads by aerosol that it's more infectious. So you don't need, and you know, if it's spread by aerosol, it can sit in the air in rooms with bad ventilation for a long time. And you don't need a ton of you know, sort of viable virus then to infect somebody. If they're in the room for a long time breathing, even with a mask, the aerosols come out, the viral particles come out, and you can spread the disease that way. So it's rare, I think, like you said, 3% in those studies that I mentioned, but it can happen.
Yeah, you see what I'm talking about, though, right? In other words, it takes more virus in you to infect another person than it does to have symptoms. I mean, I'm talking about any symptoms. And I've got a quote from the WHO, I think, on the next slide. But you know, the Mojang virus was a coronavirus that had enormous synergy with SARS-2. It was the one that Dr. Shi, you know, the bat lady, designated by a series of letters. One was RATG13. Remember that?
Yeah.
And that was changed from another sequence of letters. And people were a little suspicious as to why she changed the letters, because that may have been the backbone for SARS-2, if you want to speculate that the whole thing was made in a lab. Because remember, they have not found this anywhere yet, right?
Although I don't know a ton. Honestly, I don't know a ton about this Mojang virus. So, I mean, I know about that RATG13 virus.
Yeah,
that seems to be the closest.
The RATG13 virus was the one that they rushed down to Yunnan when these miners got sick.
Yeah.
From Wuhan, and they took samples of everything. I mean, they took samples of the miners and everything, and it turns out it was a coronavirus, RATG13. Which has like 96% commonality with SARS-2.
Yeah, I know about that. I think the Mojang virus is different, but I shouldn't talk a ton about this because it's not a virus I know well.
Let me research it, and we'll talk about it next time, because it is an interesting part of the story. So let's not make any mistakes. But that virus did not get spread to anyone in the hospital, even though these miners were very, very sick. It didn't have a furin cleavage site, so it had a much smaller viral load.
I mean, I think the thing is it's a little complicated, right? So you can have, like, pre-symptomatic is a good example, right? You haven't expressed symptoms yet. The virus is replicating rapidly inside of you. The reason you're not expressing symptoms yet is because you haven't mounted a real immune response to it yet. It's sort of like building up. You can still spread it even at that stage. I mean, and in fact, since you're feeling well, maybe you're walking around. So it's not just the biology of the virus, also the behavioral response to being in that state. Like, in that the state is, I don't know that I have this virus. I'm just doing my regular everyday things. I can still spread the thing. But I do think it's less likely. Like, I think there's something to what you say, which is right, which is that you really, I mean, if someone is sneezing, coughing, has all the, just sort of expressing then what's going to happen is you're going to be much more likely to spread the virus. So just by the physics of it. And so I think that in fact, in that same study that had a pretty low rate of asymptomatic and pre-symptomatic spread to people living in the same household, if you were symptomatic, you spread the diseases people living in the same household 1 in 5 times instead of 1 in 33 or 1 in 40.
Okay, so the point I wanted to make about that is, yes, I know you can create a scenario where an asymptomatic person could spread it to someone else, even though I don't really believe it. And the reason is let's say you're in a small room with your grandmother for 4 hours watching a movie, and you don't have any symptoms, so you don't know you have it. And you may not have a big viral load enough to give you symptoms, but I mean, enough to ever give you symptoms. However, you're every time you exhale, you're breathing out 10 million virus particles or something, okay?
Yeah.
And it will accumulate in that room that has no ventilation. You know, if it's like a den in a house with closed
Yeah.
doors and closed windows. And then maybe grandma could get it from you, even though you're asymptomatic. Now that's a scenario that could happen because the virus just floats in the air. And the more you breathe, the more and more that's going to accumulate in that room. And then finally, there's enough of it to cause a problem for grandma. You with me?
Exactly.
So there is a way that this could happen. I guess I'm having to, but in my mind, I have to create a scenario like that for it to make any sense to me.
I mean, I think that's why it's rare.
Huh?
That's why it's rare. I think. I mean, I think you're right. It can happen. It's just it's not that like it's not that it never happens. It can certainly happen. It's just rare.
But I think it has to happen in a scenario like that in a house.
And even in the house, you're still finding it's rare. It's like I said, 3%.
Again, so it's got to be some strange thing like watching a 4-hour movie with grandma in a closed room that has no ventilation.
Yeah.
Or something. And that's why it happens 1 out of 100 times or whatever.
Yeah. And, you know, it's interesting. Like, I think, for instance, in poor countries or environments where there's a lot of like slums, for instance, lots of people live together in a poorly ventilated household. You see the disease spread much more efficiently in those settings.
Okay. Yeah. Right. Okay. Okay. I think we've sort of hashed this out a little bit. I have kind of a theoretical problem with it unless you create a scenario where the virus accumulates in a really big way, like a zero, like a room with no ventilation at all and so forth. So let's go on to the next slide. Now, what breaks my heart about this is I looked up a study last night, a very big one. It was a meta-analysis of tons of papers that have been written about this. And I definitely will remake the slide for next time because I found flaws in the conclusion part of the paper. The guy got pre-symptomatic and asymptomatic mixed up in the conclusion. I'm so upset that I erased that slide. But let's go ahead and see what's next. And this basically is the slide where I say testing everyone. And I say, based on the sketchy notion that truly asymptomatic people could transmit significant virus, was a disaster in the make. Because, you know, when we started testing people, everybody, and cars are lining up by the thousands to be tested, you know, when people have no symptoms at all, that's when the cases and the deaths diverged, and that was a problem. And it happened right here, and that's exactly where the cases shot up and the deaths continued to go down. And if you look at the beginning, before they were testing everyone, and I'm not talking about scientific testing, like say when you guys did the seropositive study. I'm talking about they wanted to test everybody. But anyway, before that happened, look how nicely the deaths, which is this redder curve, followed the cases. There's even a little hitch here, and you see the hitch in the deaths. I mean, it was incredibly congruent. You see what I mean? And delayed by the right proper amount of days, and everything made sense. Then when they started testing everyone, there was so much divergence. As you can see here, these are for the Scandinavian countries, and you could have picked any country for this, including the United States. But you know, the deaths for these countries absolutely went to zero when the cases are just skyrocketing here. Much higher than when the deaths were high compared to zero. You see what I mean?
So this is through the first wave of this, right? So yes. And then into the summer. I mean, I think in the winter,
a huge problem.
Yeah, I mean, I think there's definitely some element of this, which I agree with. I mean, the policy of mass asymptomatic testing, which is essentially one we adopted, was almost tailor-made to cause panic.
Right.
What it was picking up was what we found in the seroprevalence studies, that there were a lot of people infected that just got better, but weren't particularly sick when they. So there's a range of clinical presentations for this disease. The vast majority, like there's a lot of people that have literally no symptoms. Maybe 20, 30, 40% of the people that get infected get no symptoms. They have it, they produce antibodies, and they don't even know that they had it. A lot of people just had cold-like symptoms, including the weird symptom about loss of sense of smell or taste. And it's only a relatively small fraction of the people that have the cytokine storm, have the viral pneumonia, and so on. It's just that those are the people we see. And then in the early years of the pandemic, those are the only people we saw. And that's why you see this tracking of deaths and cases that you pointed out, which is exactly right.
Yeah.
It's when we started mass asymptomatic testing, you started digging into the population. You're now identifying a lot of people that had relatively mild symptoms.
Exactly. I mean, this is why they had the infection fatality rate off by 40 times. They had it at 4% when it was 0.1%.
Yeah, I'll say 0.2, but okay, yeah.
Well, okay, we have a slight difference on that, but I'll tell you, I've got a few more things to show you that you make it lower than 0.1 even, and I'll try to give you my little description of that. But that's certainly the problem. They had selection bias. They were not counting the asymptomatic people initially, and that made the denominator too small, which made the quotient too big.
Yeah,
and this is one thing that really set the whole thing off, because when I've already showed you my little calculation that I got off the cruise ship in early March. So in early March, I was trying to tell everyone that all the experts were wrong. And everyone was saying, why should we listen to you instead of the CDC? And I said, well, I don't know, but I just did the calculation on a cruise ship, because you have to test everyone in a small population if you want to make sure that you don't miss asymptomatic cases and so forth, right? And I showed you that in maybe the first video that we did, part 1, where I derived 0.12%. Remember, from the cruise ship numbers. But
the thing about that number, I mean, I think the seroprevalence studies are really the right way to look at this. It gets more complicated in the post-vaccine era, but like before the vaccine, because the reinfection rate is so low, you can just look at the antibodies in the population to get a sense of get an estimate of how many people actually were infected in the population. So now there were 100 of these or more of these studies worldwide. The worldwide infection fatality rate, I think, is something like 0.25%, 0.27%.
Okay.
In countries that are older, you have a higher infection fatality rate. In countries that are younger, you have a lower one. And you see this massive age gradient. So the key thing is not even the 0.2 or whatever. The key thing is the age gradient.
Yes, of course, yeah. But you guys did the very first seroprevalence work, right?
Yeah, the very first published one, yeah.
Yeah, now
the very first one with a preprint.
You guys did Santa Clara County and LA County. Was that where you did it? Okay, and what were the values you got from both?
Now, we didn't look at nursing homes, so that we excluded that population. But in the community samples we were looking at, it was 0.2% in LA County and Santa Clara studies, separate studies.
Okay.
0.2%.
Wow, and you got the same in both places.
Yeah, I mean, that's the number that comes up in so many of these seroprevalence studies. Now, in places like New York that are older, there are seroprevalence studies that show a higher number, or Spain that was older. But in places that are younger, you get a lower one. And the worldwide median of
those stuff, younger in age, of course.
Yeah, younger in age.
Yeah, okay. Just to clarify.
Yeah, and so if the worldwide median across all of those studies is 0.27%, I think John Ioannidis, a professor here at Stanford, a very famous professor, published a meta-analysis of that literature in the Bulletin of the World Health Organization, and it was 0.27% worldwide.
Okay. All right, so the next slide would have been the one that I showed that the guy that did the meta-analysis messed up by confusing pre-symptomatic and asymptomatic, because I'll get the exact quote, but basically what he said is, in both pre-symptomatic and asymptomatic, so much time elapsed before they got symptoms. So he's, asymptomatic people never get symptoms the way I define asymptomatic.
Yeah.
Pre-symptomatic people are just earlier in their course, and they're going to get symptoms in a few days.
Eventually, yeah.
So those are different groups of people completely. Now,
Yeah.
I did try to come up with an explanation that would explain why some asymptomatic people can transmit it, because I just wanted to try to support the paper that you found and have it at least make a little bit of sense to me. I've derived, I think, because of this study, where half the people in the study that were truly unexposed had T helper cells to SARS-2. Now, I've shown this graph. That was this slide was one of the two most important slides of the whole pandemic, in my opinion. That's the way I introduced them last time. And if you've got people going around that have immunity in place because of cross-reactivity with previous coronaviruses, and they get a viral load, they breathe in a viral load, they will make an antibody response to it, even though they're protected and will never get a symptom. Just like someone that has the measles could be in a room with you and give you a bunch of measles virus, but because you're protected, you're not going to get any symptoms of the measles. Would you agree with that?
Yeah, that's true.
Okay, now, so those could be the people that are truly asymptomatic that also could conceivably spread it to someone else, because you think about the timing of it. You know, if somebody that has a lot of viral load watches that 4-hour movie with me, I'm going to get a lot of the virus in me. And if I had immunity in place, if I did, then I'm not going to get sick even from that big viral load, because I've got everything at the ready by clonal memory, right?
Yeah. I mean, I think
just like
there are some complications, right?
But for a little while, I'd be able to transmit it to someone else, because it would be all in my nasopharynx and oral pharynx for a little while.
Yeah.
And I'd be able to breathe it out into grandma if we watched another movie the next night or something. You see what I mean?
Yeah.
So it is possible that an asymptomatic person could spread this if they had immunity in place. And there are a lot of people that have this. I mean, look at this study of random people who were unexposed. Half of them had T helper cells for SARS-2. They never been anywhere near SARS-2.
I think what you say is, I completely agree with. It's very important. I mean, there are other groups also, like you can imagine someone whose immune system is depressed and they don't mount an enormous response to the virus. It doesn't look like they have a lot of symptoms, but the virus is still replicating in them for a little while.
Yeah, that's why I put this little tiny caveat up here to people whose immune systems are healthy. You have to put that in, or you do not have anything to discuss, really. It throws everything off.
But I think the key thing from the epidemiologic point of view, and you is right. This is rare, and the mass asymptomatic testing essentially then is picking up a lot of people who they're not likely to they're not the ones that are like developing the severe disease.
Right. Well, here's the thing.
Question is,
just let me ask you this, because you're the expert on this study and everything. When you guys did this seroprevalence study, you're looking for antibodies, of course, seroprevalence, right?
yes.
Okay. A person who has immunity in place will not have antibodies. They will be missed as part of the herd, correct?
That is correct. So we only looked for IgG and IgM. We did not look for IgA, because there was no test available for IgA at the time.
Okay, good point. You're talking about secretory IgA or circulatory IgA?
We didn't look for either, because we couldn't.
You took blood samples, though. You took blood.
Yeah, we had blood samples, so it's seroprevalence. But we only look for IgG and IgM because we didn't have a survey or like a testing technology that would identify IgA at the time.
Okay, so these people would have been missed as people who are protected and part of the herd, correct?
Correct. Yeah.
All right, but if they did get infected, they wouldn't get symptoms, just like you wouldn't get measles.
Yeah, no, I mean, you're right. I mean, in that sense, we underestimated the extent of the spread of the disease, and of course, I mean, even with that, we almost in our samples, something like 30% of the sample or 40% of the sample was asymptomatic. They did not remember having any flu-like or cold-like symptoms or coronavirus-like symptoms in the past, several months.
Yeah. So I think now I'm speculating, but I think some of those people had antibodies to SARS-2 that you picked up, but they had immunity in place. And that's why they didn't get any symptoms.
Yeah,
They
no, I
still
think
would
you're
have,
probably
they
right.
still would have antibodies in their blood though. If someone had given them a viral load, they'd still make antibodies to it, but they'd never get symptoms. And I think some of those people, I'm speculating, but it makes logical sense to me. Some of those people in your study had immunity in place, and that's why they didn't have any symptoms from this.
Yeah, I think you're right.
Yeah. Okay. Now, the next thing, can you get, now I'm talking about pre-Omicron and pre-Delta even, can you get COVID-19 twice? And I know we had a slight disagreement on this. I'll tell you, it's possible, but it's so rare. We're talking, let me just jump to the chase here. The WHO at one point said that of the 780 million people who had been exposed, so I know about this a lot because I did a calculation at this time. This is in September of 2020. They said 10% of the world had been exposed to this. And the world has a population of 7.8 billion at that time. So 780 million people had been exposed, and there had been only 6 or 7 with documented reinfections. That's 1 in 100 million people.
So the
According
number
to
I've
the
seen,
WHO, it's hard to believe, isn't it?
I mean, I agree with you. It's rare, although the number I've seen is a little bit higher than that. So the number I've seen is based on, for instance, there's a study in Lombardy, Italy, and they tracked people who had documented cases of COVID in the early days, because remember, Lombardy was hit very hard. And then they tracked them for a year, and they found it was 0.3% were reinfected in that year.
Okay, that's a lot more than 1 in 100 million.
I know, that's what I was saying. It's a little bit larger than what you said, but it's pretty small, Reed.
It is, but here's my point though. I mean, this is the basis for everything in immunology, is that you get clonal memory that protects you from getting the disease again. And so
I will say this: the other important thing about that study, that 0.3% of the thing is important, but it's not the most important. The most important thing is that of those 0.3% that were reinfected, I think there was only one patient that was actually hospitalized in the second time around.
Yeah, that makes sense. They would certainly have a less severe case if they were reinfected.
Yeah.
But my point is, I mean, would you get the measles if you got a bunch of people with the measles in the same room as you? You wouldn't get it. You've got too much clonal memory for it. And you've got a live attenuated virus in you that's making these reinforcing your immunity all the time. It just goes against everything that this stuff is based on. Now, let me just make a quick point though. When I gave some live lectures last fall on this, and I explained to people what clonal memory was, that it protected you, and you haven't gotten the measles since you got the vaccination or the disease when you were a child. And about almost 10% of the audience stood up and said, well, I've gotten it twice. And one lady stood up and said, I've gotten it 3 times. She's talking about COVID. And very politely, I tried to tell her that, she probably had maybe the flu one of those times, and flu symptoms, and thought she had gotten COVID again, or maybe bacterial pneumonia or sinusitis or something that had a symptom overlap with COVID. But I'll tell you, I don't think anyone in that auditorium had COVID twice. It's so rare. And the WHO even said it's, now let's say they found 6 or 7 documented reinfections. Well, that means that there's multiples of that out there, because they don't hear about all of them, of course. But it's just, it just doesn't make sense that people would be getting reinfected. So here's a proposal I would make. If you really want to prove that someone has gotten it twice, you have to have symptoms from it twice, some kind of symptoms. You have to, because you can get antibodies to something and not get any symptoms from it, not get the disease at all in any kind of reasonable definition of it, if you have immunity in place. And people that have gotten this have immunity in place. That's the whole theory behind vaccination and everything else. So what I wanted to say was, if you really want to do this, there's some things you must do. One of them is you've got to find someone who has symptomatic illness more than 3 months apart, with a completely asymptomatic period in between, okay, with negative PCR tests in between. And you have to culture out the viruses both times because the PCR test is so bad. And you've got to make sure that they sequence exactly the same too, to truly say that you were reinfected. Because, you know, Omicron has mutated the DNA or the RNA in Omicron has mutated so much now that certainly people that got COVID 2 years ago can get Omicron now. Because the protection they got for COVID, for the spike protein and everything, it's possible with all, I mean, Omicron has 36 mutations in the spike protein, I heard, or something. So it's possible for people to get Omicron. I'm talking about getting the same one twice. You see what I mean?
I think so there were some studies like that actually did the sequencing, and they documented, again, symptoms twice. They sequenced and it was a different one. Of course, those kinds of studies are very hard to run. And you have to have, so it's not surprising that those kinds of documented cases are not common in one sense. But it's still rare. I guess the only disagreement is whether it's zero or rare.
Right.
And I think I agree with you. You get pretty like against if the Wuhan strain were to come back into circulation, a lot of people that had it before, I mean, a lot of people had it before, those people would be, I think, pretty much immune. I think
just like my immunity in place logic. But
yeah,
those people it wouldn't cause much of it wouldn't even cause a visible
blip.
bump.
I mean, I think that, and that's why, for instance, the virus mutates, because it no longer has the ability to cause the disease, replicate itself, and pass it on. It mutates in order to escape prior the immunity in place caused by the prior success of it.
Yeah, I think viruses are one of the most interesting things in all of biology because, you know, it's all they really are is a capsule with a genetic material inside. You wouldn't say they're living things, but they almost have a brain. You know, they know that they need to change the spike protein a lot.
Well, you know, this is one of these things about evolution. Like you of course, in evolution, there's no like direction into it. And of course, there's no thought into it. But it's almost impossible not to talk about it and anthropomorphize it to some extent when you talk about it.
It's like viruses are really smart. Of course, they're not.
Yeah, exactly.
But there has to be a survival advantage to wild mutations in certain parts of it. Otherwise, it would not survive, obviously.
Exactly.
And we're getting ready to talk about herd immunity now. And this is one more tiny little clarification, but we're getting ready to talk about herd immunity. And that's what happens in herd immunity. The virus runs out of people to infect. We'll talk about that graphically in a second. Let's just cover this last topic. Now, we had a very slight disagreement, I'll call it, on lockdowns. I think that lockdowns in and of themselves, I'm not talking about any collateral damage, killed more people than they saved. And I've got some evidence of it. The first piece is, again, I presented this last time. It was when Governor Cuomo came on CNBC, and I remember this because I saw it live. And he talked about the people that were having the hardest time with this so far, you know, going to the hospital more often, getting sicker, dying more often. Of course, it was predominantly older people. We know that. But it was also people who were not working, who were not traveling, who were predominantly at home. See, the people that were locked down went to the hospital and got sicker more often than the essential employees did. See, predominantly non-essential employees. Those were the people that stayed home, right? And I felt sorry for him because he was trying to justify everything that was exactly the opposite of what all the politicians were selling to everyone. But these were the findings from the initial part of the lockdown. It was people that were non-essential employees that were getting sick. The garbage man and the lady at the checkout counter at the grocery store, with thousands of people going by her every day, did not get as sick as people who went home and locked down. And I do have some reasons for it, but isn't that amazing? And that kind of contradicts a lot of what people have said. Now, I know that you made a very good point that the laptop set had much less trouble than the people who were not in that social strata. socioeconomic strata, correct? Was the ratio 3-to-1, you said, or something?
I mean, let's leave aside the exact numbers. I think the key thing, this is a complex sociological problem.
Yes,
Uh, and
very
it, and it,
complex.
and so just if you think about, and to me the main thing is the collateral harms from this overwhelm any of this calculation.
Of course, it completely overwhelms it, but I do think there's validity in really understanding how severe the error of lockdowns was.
So let me just, did we talk about that Hopkins meta-analysis last time?
Yes, yeah. And Hopkins said that there is a little tiny advantage of having a lockdown.
Yeah, but it was not, I mean, there was
about the collateral damage, of course.
Yeah. I mean, I think the thing about lockdowns, the reason why they would have zero or even negative effect, as you say, is because, okay, so if people think about lockdowns and they're attracted to them because there's a physics that they have in their heads, and Aristote's physics, that if I just keep two people apart from each other, they can't spread the virus to each other.
But they're wrong, though. They've got the physics wrong.
Yes, and the reason is it's not the physics that's key here. That's the sociology, right? So human societies can't operate that way. You can't keep people apart from each other all the time.
That's one of the reasons they did worse. And
they're unequal, and so the relatively well off can protect themselves. They have at least the better capacity to protect themselves.
Right.
If you ask the whole world to lock down, you're going to get a lot of less well off people who really can't afford it, that their family would starve, that would actually not lock down because otherwise they would be harmed. Now, let me give you one piece of evidence on this from a study done in India, in Mumbai, and again it's seroprevalence in July of 2020. August 2020. The finding was that in the slums of Mumbai, seroprevalence was 70%. In the rest of Mumbai, the relatively richer parts of Mumbai, it's 20%.
Okay.
So there's this huge gradient, socioeconomic status gradient in who actually has the capacity to lock down.
Right. Yes, absolutely. So what I wrote here is essential workers did better than people locked down at home. So if the laptop set did better, and I do believe they did, and you've got the proof of it in your research, right? They did so because of reasons other than being locked down at home.
Yeah,
Let
I mean,
me just give you a thought experiment that I think would show something very important. If you take people in the same socioeconomic class, be it rich people or poor people, but limit it to one class, and you lock down half of them and you let the other people go about their lives, the people that you lock down will do worse. Again, because of the social nature of people, there'll be more alcoholics that come out of that group.
Yeah, but I would call that a collateral harm. I wouldn't call that in terms of just pure protection from COVID, if I hide away in my house for 2 years, I mean, and I'm alone, I literally am alone for 2 years, I physically not in the presence of anybody else, I'm really unlikely to get COVID. That's all I'm saying.
Yeah, well, let me say this. You may be a little bit more unlikely to get COVID. I'll give you that. However, you're much more likely to have a problem with COVID because your vitamin D is going to be lower.
See, now those are all, I agree with all that. Maybe this is just terminological.
You're not going to.
I mean, Reed, I think this is just a terminological issue because I would call those collateral harms from lockdown. And I completely agree with you, right? You're going to get depression. You're going to, we really aren't meant to live apart from each other.
Right. But okay. I mean, you would call having your vitamin D go way lower a collateral damage from a lockdown?
Yeah, I mean, I think so. I mean, of course, it can raise your risk of getting COVID. Were you in the presence of people with COVID, but you're hidden away? I mean, in this thought experiment from anyone else.
Okay, can I throw one more little? All right, then we'll leave this because I'm using some things that I don't consider collateral damage, which you do, and that's the difference. Let's say, but do you know about this expedition that occurred in the 1960s? when 12 explorers went to Antarctica, and they were all tested extensively before they left. Of course, they didn't want one of them to be sick and give it to all of them when they're way out in Antarctica in the winter. And they all tested negative on everything, okay? So they go to their camp in Antarctica, and for 17 weeks, nobody gets sick at all. Nobody. And then on the 17th week, one guy starts to get a stuffy nose and the sniffles. And then within a week, 9 of them had it. So how did that happen?
This happened with COVID. It literally in Antarctica, there's, I think it was actually, it's either Antarctica, I can't remember if it's Antarctica or Arctic station. There's a Belgian group of scientists tested negative extensively, and there was a COVID outbreak in this like remote station.
Okay.
The same thing happened with a fishing boat where they were out in sea for a long time.
Yeah. So do you think that staying in your house, now here's the problem I have with this physics wise. Sure, if you stay in your house for the whole time, you're going to say that my chance of getting COVID is almost zero. I didn't quite get what you said there. Was it?
Yeah, like
lower?
if I'm completely isolated from everybody else since February of 2020, my likelihood of getting COVID is pretty low.
Okay, but here's the problem with that. You can't be completely isolated or you'd starve to death. I mean, there's going to be some delivery boy that brings something to your house to eat. So he stands on the porch of your house and rings the doorbell while you're watching TV. Now, he's got COVID and mild symptoms, but he's still going to go to work, right?
I mean,
so he's standing on the porch of your house in a still night, and he's breathing COVID out like crazy on your porch, delivering a pizza or something, and you open the door and suck tons of COVID right in on top of yourself.
So, Reed, I guess the question is what exactly are we talking? So, like, I think, for instance, that evidence in out of India and Mumbai, there's very clearly the laptop class was protected, right? The people in the rest of Mumbai, rather than the slums, had a much higher, they had a lower seroprevalence.
Right, but was it because the people in the slums live on top of each other, which they do, and the rich people have big apartments?
Yeah, they're relatively isolated. They're relatively capable of isolating.
Or was it because the rich people have better health in general, much higher vitamin D levels on average?
I mean, I think there's some of all of the above.
Everything that's healthy, the rich people have over the poor people.
I think it's all of the above, Reed. I mean, the germ theory is true. If the germ theory is true, then what matters is, at least in part matters, is, are you exposed to the germ? People who are locking down, who actually can afford to lock down, can reduce their contacts relative to the people who can't lock down. And so if the germ theory is right, you're going to get less likely to be exposed and less likely to get sick. Now, there are complications. So that's the germ theory is right, but the complications are exactly what you say, like what's the health status of the people that are locking down? I mean, but I think even if after you control for that, you're still going to find that the lockdowns, I mean, there was some class of people who actually could protect themselves. I mean, I think you kind of see this with Omicron. Like, a lot of people who got sick during Omicron were these laptop class people who had convinced themselves they could protect themselves from COVID forever. And they're shocked when you have a much more transmissible form of the disease going around to find that they can't.
Yeah.
But they did protect themselves for much longer than people who weren't in that class.
Right. Yeah. So it's associative, though. So we don't know all the factors. We certainly didn't control for all of them. So we'll never get the true answer to that. But I do think you're right about that to a great degree. But it's just a matter of time, though, because you're talking about all these crazy macroscopic solutions where you're closing a door, basically. And this thing is so small. It doesn't matter whether a door is closed, sealed, locked, anything. It's like throwing a BB into a garage door, through a garage door. It goes right in to the person's house that's locking away. Now, if you created the ideal situation to lock down, and that would be with enormous ventilation in your house, all the windows open, fans blowing air everywhere all the time out the house. I agree that you could lock down that way, but that's not the way people lock down. They didn't understand it. They locked down in low ventilation places. So the lockdown people did worse, and that's proven right here. I mean, these statistics here that Cuomo is trying to justify make no sense. It tells you lockdowns are the wrong thing to do. And then, of course, I've already showed millions of graphs of countries. You can't tell which countries locked down and which didn't by the shape of the graphs. That's real. That's the real proof, a la Dr. Feynman's quote that I read in the first part that we did.
I guess I didn't know. I didn't follow this. What exactly did Cuomo say? So he's saying that there's a correlation between not working and not getting COVID.
Well,
not working and getting COVID.
This is the list here in white is a list of the people who did worse, who were getting sicker, going to the hospital more often, and dying more often.
Okay, so like dying and getting are two different things.
Is older people.
Yeah, so dying and getting the diseases are two different things, right? So a lot of people who were younger got the disease that didn't have a very severe reaction to it.
Correct.
So I'm not sure I understand exactly what Cuomo is saying here. Is he talking about who's dying?
He's talking about by extension, because he's talking about who went to the hospital here.
Yeah, so that's a difference. So that's a difference. There's two steps there. One, you have to get disease, and then you have to get sick enough with the disease to wind up in the hospital.
Right. So here's what it is. You take a kid in college, and he's very likely to get the disease, right? He's going to parties. A lot of people don't have much symptoms, so they go to the party too. So it spreads like crazy among young people. Would you agree with that?
Yeah, I think
when they closed the universities and sent those kids home to lock down in someone's house where grandma lives, that was a big mistake, because they created a situation where an older lady who's very vulnerable to being sick enough to go to the hospital is living in the same house with poor ventilation with a 21-year-old or a 19-year-old that has a cold-like symptoms, but he's going to give it to grandma. She's really susceptible in the same house with someone who's pumping it out of his mouth all day. She's going to get it, she's going to get sick, and she's going to go to the hospital. And that's what happened. That's why you had older people who were locked down. Locking down and being old, being a minority, all these things made your course worse. See, predominantly at home. Non-essential employees, those are the employees that were allowed to stay home and work from their
I think if you look at healthcare workers and other I don't know when the slide was, but I don't think that's right, that the non-essential employees actually had better COVID outcome or worse COVID outcomes. If you look at okay, let me just give you another piece of evidence, right? So if you look in LA County on who died from COVID, it's people living in the richer or the poorer parts of LA County.
Yes.
It's Hispanics that were working.
Makes sense. Because it's the same reasoning though. It's because in those families, culturally, the grandmother, the parents, and the children, and maybe even great grandchildren will live in the same house.
Well, let me give you another piece of evidence. If you look in Florida, which didn't have a particularly severe lockdown, you actually see equal outcomes by race and by income.
Okay, so
the lockdowns accentuated the pre-existing inequality, and it's the relatively poor that ended up having to work, that ended up having to get exposed. The lockdowns. So I guess the only part I don't understand, Reed, is what you're saying is like you're saying the lockdowns didn't protect somebody, but I don't think that's true. I think there's a group of people who were protected by lockdowns. I don't think there's a large group of people. It's a group of people who were relatively well off that could actually afford to stay home.
But you're talking about people that don't live in a family that has grandma, themselves, their children, and their grandchildren.
It's a complicated sociological thing, but I'm not saying that the lockdowns were effective as a general matter, and I don't think it was possible for it to be effective over a very long period of time. but I mean, to exclude that there's anybody protected by them, I guess I don't think that's consistent with the evidence I've seen. I mean, there's some people I think that were. It's just organizing society around protecting that group of people
Well,
that tended to be younger, tended to be richer, made no
yes.
sense.
Okay, yeah, I agree with that too, because it was, I agree with that.
I mean,
But
I think the question is one of exposure versus severe disease. So this slide mixes up exposure plus severe disease. What you want really,
well,
if you want to like answer this question again, is a seroprevalence study. You want to know the correlation between exposure to the disease and as evidenced by antibodies in your blood at a population level.
I agree with that.
Yeah.
I'm in total agreement with exposure. But this was, Cuomo had no way of knowing what the exposure was. He only knew what the hospitals were telling him of who was coming in and hospital counts. Now, he does have access to that information, but he doesn't have access to exposure. This is all about who did very poorly enough to go to the hospital. And I'll tell you, in New York at the beginning of this thing, a lot of those people died for many reasons. One of them was they were being ventilated, they weren't being given the proper treatment, I'll say, and so forth. But I agree with you. There certainly is a section of wealthy people, like you say, the laptop set, I think you called it, right? And that I agree with that, because those people generally don't live in families where lockdowns cause a big problem. That lockdowns cause a far less problem to them than it would to a poor Hispanic family in the east side of LA, for example. Because again, they're going to have, I'm talking about in general now. There are many more of those East LA Hispanic families, Mexican immigrants, that where grandma lives in the same house as the grandchildren. Would you agree with that?
Yeah, I mean, I think
that's why it hurts that set of people worse than two rich professional New Yorkers that live in an apartment in Manhattan. They can really benefit by the lockdown.
Yeah, that's all I'm saying. I think there does exist a set of people that would benefit.
Now, okay, I will give you some information. I do think this is fairly early, by the way. I think this, if I remember correctly, this was kind of early when everyone was all tense about it. Might have been in April or something, or May, maybe, but probably April. I should have the date on this. But a study was done on people who do checkouts at the grocery stores who were essential, right? And they were coming in contact with person after person, but not for very long. That was the key. And they had no higher incidence than anyone else.
Yeah, I mean, there was a study done in Sweden, for instance, of teachers and teachers in Sweden, they had no social distancing, no mask, nothing. And they actually had lower rates of COVID than the rest of the community.
Right.
I mean, I think it's complicated. It depends, right? So like children, for instance, don't spread the disease very efficiently.
That's why the teachers did so well. They were spending their whole day with people who couldn't give them the disease.
And classrooms in Sweden might have good ventilation. I mean, it is going to be a complicated story.
Yeah, it's
a sociological story about who's benefiting, who's not benefiting from the lockdown. Yeah. My point is that there's a class of people that actually benefited from lockdowns, that by reducing, that actually was able to reduce the exposure to the virus. Yeah,
but net, it was a killer of more people than they saved. They did save the rich.
Again, if you're talking about like there's no question about that if you account for the collateral harms, right? So for instance,
I'm not counting collateral. The collateral harms is a million times bigger than this. I mean, it's a no-brainer to say that.
I mean, I think the number.
So it might have helped a little subset of the population, the laptop set, and it is a lot smaller. There's a lot more poor people and lower middle class people than there are rich people in numbers, as you know. So it might have helped the laptop set. And I agree with you that it did. Okay. But it hurt the other people very severely to be locked down. It was, and I'm not talking about collateral damage. I'm just talking about
that. I think we don't disagree on this at all. Then.
Okay.
I mean, because I think for someone living in the slums of Mumbai, the lockdown was a devastating thing for them. Like it
Right.
really actually probably exposed them to COVID because they had to sit at home with
Sure.
13, 15 other people in a small house with no ventilation.
Absolutely.
And as you said, with like you send your college students back home, you created multi-generational homes.
Exactly.
No, so in that sense, the lockdowns, I mean, you know what it was? The lockdowns were focused protection of the laptop class. It was not, it was focus, it wasn't focused protection of the vulnerable. It was focused protection of the laptop class.
Right. And at the expense of the vulnerable, I would even say.
Yes.
Yeah. Okay, good. I mean, you know, we're talking about such fine points as we discuss these things, which I do think is helpful because it helps the viewers understand it really well, number one. And number two, this stuff has to be hashed out because I'll tell you, there's people who still believe in lockdowns out there. I'm telling you.
I mean,
it's
are they watching what's
incredible.
happening in Shanghai?
Look at that. How could they possibly do that after all this data has come in? And they still
Yeah.
did it. It blows my mind. You know, that's one of the things I don't understand about things. And that is, I can understand a lot of the mathematics and physics of all this and look at the graphs and draw correct conclusions. But I cannot figure out why people could possibly think that lockdowns still work enough to lock down a city like Shanghai. I've heard there's people almost starving to death now that have been locked down because when they do a lockdown, they put a guard outside a metal door, you know, they don't let anybody out.
Mm.
But I'll tell you, Jay, we need to hash this out because this should never happen again, in my opinion. This
That I
is
agree
a
with you.
macroscopic solution to a nanoscopic problem, which will never solve it. That's why these people in Antarctica and your example eventually got it. They were thousands of miles away. Talk about social distancing. They were thousands of miles from whoever had it. And somehow it got into their camp. And it could have been a bird or whatever, or the wind. Something got the cold virus into that camp after 17 weeks, and all of a sudden they all got sick. That shows you that distancing and all that. I don't know. All right. And MIT did that study, but let's not talk about it. Let's move on.
By the way, I just checked. It was actually Antarctica.
Yeah.
that
Okay.
this
You
happened
may be
again.
thinking of the same one then. Same study.
No. This I'm saying for COVID. So you were telling the story for
Oh,
pre-COVID.
no. I was telling it for influenza or the cold. Yeah.
Yeah, this was for COVID. There's actually, I'll put it in the chat so you can share it with your audience next time.
Okay, so there you go. You see what I mean, though? All right. But anyway, here's a graph from Oxford, and it says the fatality rate is higher in countries with longer lockdowns, and it's triple. The rate is 3 times higher in and of itself for the lockdowns in the countries that had longer lockdowns. The fatality rate is higher, and this is not collateral damage here. All right, let's move on. Is that okay to move on?
So I think that so now there's that Hopkins study which has looked at this for and this is fatality from COVID.
Yes,
or all but there's also studies
well,
that
actually I don't want to say that necessarily. I don't know because something could have slipped in that wasn't COVID and raised the fatality rate. So I don't want to say that. But Oxford University did this, and you can see they did it through quite a long period of time. They did it from April 15th of 2020 all the way to the 26th of August. And it stayed very consistently higher than people who had lesser lockdowns.
I think so there's some work that's been done that's tried to look at all-cause mortality.
Yeah.
Excess all-cause mortality. I don't know. When I look at these data, I see no correlation with lockdown. I don't see the lockdowns kill in and of themselves. I mean, I think they kill via collateral damage, but in and of themselves, I see no correlation between lockdowns and all-cause mortality, or lockdowns and even COVID mortality.
I think the lockdowns. Sorry, go ahead, Jay. I'm sorry.
No, sorry, Reed. Go ahead.
I'm so keyed up about this because I think the lockdowns were in school closures, which were lockdowns too, of course, part of the same.
No, but school closures, that is a collateral harm.
Oh, it was the worst thing that's ever been done in the history.
Yeah, but that's a collateral harm. So we're trying to distinguish between the effect of the lockdowns on direct effect on mortality versus the effect of the lockdowns as taken globally.
I agree.
Taken globally, I think we don't have any disagreement. I think
Well,
taking
no
globally,
disagreement at all, if you include the collateral damage. I'm only
yeah,
talking about in
I
and
think
of
that
themselves. And what I mean is, do the thought experiment. I just had it in my head. I'm getting old. I forget things now. But the thought experiment is, take people where you've controlled for everything, where the type of house they live in, what kind of job they have, whether they can work with a laptop, even how big their house is, whether it's a couple that lives alone with no kids, whatever. Take a subset where the subsets are exactly the same, and you lock some of them down for a year, and the other people are allowed to go about their business. The people that are locked down are going to do worse. That's why they put prisoners in solitary confinement when they want to punish them. It's much harder to live in solitary confinement than in the general population in a prison. That's how they punish prisoners, is put them in solitary confinement. So when you lock people down, I'm not talking about collateral damage. It depresses you, which is bad for your immune system. It does all kinds of things to you. I'm not talking about pushing more people into poverty. I'm talking about just people that have to be isolated from other people when the physical part of the lockdown does not work. Now, it might, on the margin, it might help a little bit, but I'll tell you, if the people in the rest of their apartment building are going about and getting sick with COVID and everything else, it's going to get all over the building, because the closing a door does not do
yeah. So
anything.
again, I think it's for this question of in and of themselves. It's a complicated sociological question.
It is
My
very
read of the
complicated.
evidence is that it's uncorrelated, that the lockdowns, but also quite unequal. There are some groups of people that
Yes.
it helped, and like again, the rich.
That's why I said you have to control for every difference in the people.
Yeah.
It's
So
really
I
important
just
to know.
so I
But,
think okay. I think we've reached.
yeah, we have, and I think it's been good to hash it out, don't you? I mean, it's
Yeah.
just
No, I mean, it's this is how science works, right? Reed,
Yeah.
you talk through, you look at data together and see how we think differently about it.
Yeah. Okay, great. Thank you very much for your opinion.
I don't think we actually think differently
I think
about it
we
either
were
that much.
very, very close. We both absolutely think lockdowns were the worst thing that's ever been done.
Yeah, that is
For
true.
school closures. Okay.
It's funny, like I find myself defending, saying like that. I'm on the side of like it. Well, the lockdowns didn't kill it in and of themselves.
Okay.
It's weird. I'm usually on the side of like excoriating lockdowns.
Sure, I know you are. That's why it's a little funny for us to we cut such fine hairs on some of this stuff that you almost have to defend the side that you don't believe in, just statistically, which we should do though. And so I was trying to think, why would this happen? Well, vitamin D levels are very important. Now, this right here may have been an associative study, but I did a whole video on vitamin D. I tell you, it took an hour and a half because I talked about everything involved with vitamin D, all the reactions and everything about activating, getting the activated kind and the kind that you take in a jar, the D3, and how long it takes to get to the active form. People were doing studies where the people left the hospital 7 days later, and it takes 2 weeks for vitamin D3 to get converted and get into the tissues in its active form. So it was the dumbest study in the world. The people left before it could possibly have made a difference. That's why the placebo group looked like the treated group. That was a study in Sao Paulo, but I found one in Cordoba, Spain, that really was done pretty well. They gave them cholecalciferol, the one that's the 25 hydroxy, but you need 125 hydroxy vitamin D. That's the active one. But if you give them 25 hydroxy, it bypasses the change in the liver. And so it gets into the tissues very quickly. And that study showed a clear difference between the people who got vitamin D and those who didn't. Okay.
I'm convinced by the vitamin D actually.
Yeah,
so there's some pretty good at least observational studies that people who are vitamin D deficient.
Things. It's so blatant. I mean, these are the people that survived when they had a high vitamin D, and above 30 nanograms per milliliter is not high. I'd like people to be 50. But even when you're just above 30, everyone survives. And when you're less than 20, not a single person will survive COVID now. This is COVID. And even if you're between 20 and 30, I think it says there, 90% of the people survive it. So the value of vitamin, and look at the graph here. You're okay, As soon as you get around 20 to 30 and you get lower than that, everybody dies. It's amazing. But look at the numbers of where people are in the United States. Everyone's below 30, male and female. And look at this, you got 80% of the people with either insufficient or deficient vitamin D. And that's a major problem. Now, this brings up another issue that I talk about later in our slides, and that is, why wasn't the mainstream media telling people every single night to take vitamin D during this thing? You almost never heard it. I even had this discussion with people in 2020. I said, why isn't the mainstream media telling people to get their vitamin D in order? That's way more valuable than anything they preached over the television. You know, you and I, we just got through talking about lockdowns, but this is one of the reasons the people that stay indoors all the time, they don't get any exercise, they don't get any sun. And as you know, 90% of your vitamin D gets converted from UVB rays impinging on your skin. You know, it converts cholesterol to the metabolite, to the precursors of the active form of vitamin D, 90%. So getting out in the sun is very important. And that's what happens when you're in lockdown. You don't get as much sun either. So
my friend, the Surgeon General of Florida, Joe Ladapo, Dr. Joe Ladapo, that's one of the things that he's taken on himself is messaging, is telling people to go out, go in the sun, go exercise, it's good not just for COVID, Reed.
I
it's
know
good
for everything. I'll tell you, when I learned about vitamin D, its effect on COVID survivability, I found out so much about vitamin D. Everyone should get their vitamin D in order. It affects so many diseases and processes.
And actually, forget about supplements. If you can get it by going out in the sun, and you live in a place where that's possible, definitely do that.
Now, you know about the 36 parallel problem? If you live above the 36 parallel, just the angle of the sun on the earth in the winter will make it so that you cannot get enough sun to convert enough from UVB rays. Above the 36 parallel, or below it if you're in the southern hemisphere, right? Above the 36 parallel, almost the entirety of Europe is above the 36 parallel. It's not very high up on the globe. It goes right about through Los Angeles, just above it, and right about through the border of Georgia and South Carolina, right through there, okay? So almost the whole country of the United States lives above the 36 parallel, where they can't get enough sun in the winter. And plus, of course, people are wearing coats and gloves and shoes. They're blocking most of their skin in the winter anyway when it's cold, right? And of course, that's another reason why masks should not be worn. You're getting half of your exposed skin blocked by a mask in the winter. So you don't get any sun on your skin. So your vitamin D just plummets in the winter. You see what I mean? See how all this is related? Okay, let's go on to herd immunity. Oops. Oh, I'll tell you, this to me is a huge part of this, because we talked about a minute ago the infection fatality rate, which I came up with 0.12 from the cruise ship, right? And you guys did it much more scientifically and came up with 0.2 and so forth, right? And worldwide it was 0.25, you said?
0.27, something like that, yeah.
0.27. Now, I'll tell you, we talked about the denominator an awful lot when we found the error that the experts made in the IFR, right? It was a denominator problem. But I'll tell you, the numerator is wrong too. It's way too high. The deaths.
So for the numerator, it depends on the country, right? So like there's a fantastic study that John Ioannidis did looking at overcounting and undercounting, just based on and what his conclusion was that there's likely overcounting in rich countries, likely undercounting in poor countries. And the reason is that the poor countries, they don't test a ton. And so there'll be people dying actually from COVID that they never knew had it. Whereas in rich countries, they're like in the United States, for instance, there's we were assigning, we changed the way we counted, we did death certificates so that we're counting people where COVID is just incidental. They had COVID when they died, but the COVID wasn't the proximal cause of death. And there have been a few studies, like in Santa Clara County and Alameda County, of death certificate audits that estimate something like 25% overcounting.
Okay, now hang on to that thought for a second. As you know it well, we talked about it last time with Alameda County and stuff. They published that it was about 25% overcounted, right?
Yeah.
If you really think it through, there's many other ways that cause them to overcount. For example, I'm telling you, I think the number of deaths is the only disagreement we have here is that I think the overcounting was much, much worse than 25%. And let me tell you why. So we got this issue of with COVID or due to COVID. And I think that's what the 25% is about. Is that correct?
Well, I mean, I think the thing is like, as you know, Reed, because you've done this, I'm sure, when a doctor fills out a death certificate,
yeah,
you have to make a clinical judgment about what the proximal cause was.
Right.
And often you have a complicated patient with many underlying conditions. It's not the most obvious thing. It's a term of art, like what the most proximal cause was. And so like I did the example, if you have a patient who's diabetic and that diabetes leads them to have coronary artery disease, they get a heart attack, their lungs filled with fluid, and then they get pneumonia and they die. So which was it that killed them? The diabetes, the heart attack, the coronary artery disease, or the pneumonia?
I agree, but the hospitals counted all of them as COVID.
Yeah, so that's what the audit tried to do. Is they said that, okay, well, if you look at these death certificates, is it clear that COVID was the proximal cause? And that's where they got that 25% number from.
Right. So in my little study here, you're going to put 0.75 as the factor you have to put in for that problem. Okay, calling everything COVID. 0.75 of the things that they called deaths were really due to COVID. Is that fair enough?
Sure.
All right. Now, there's other major problems, though, I'll tell you. Number one, the people that were tested when they went into the hospital, and they tested everyone that went into the hospital. You know that because the hospitals were getting paid for everyone they tested. So they tested everyone with a PCR test. But the PCR test does not measure active virus. It measures RNA. And RNA can stay in your nasopharynx months after you've recovered from the disease, right? So they do a swab, they get some RNA from a disease you recovered from a month ago, and they run the PCR test maybe to 40 cycles, and it comes up glaringly positive. And they call that a positive COVID patient. And when they die of anything, it's called a COVID death. That's one problem, right? That's a very serious problem. These things stay positive for a long time after you've recovered. Because again, they're only measuring the RNA. They're not measuring active virus, right?
Yeah,
now,
you talked about that.
Here's the other problem. A lot of those people not only had COVID a long time ago, but never had COVID. Because when you get a positive result on the PCR test, depending on the false positive rate, the false negative rate, and the prevalence, you would be shocked to find out that an enormous percentage of those who are told they are positive got the incorrect result. And it's shocking. And for example, I mean, you want to just throw me a prevalence that's reasonable? Was it 1%? Was it 3%? I don't know. If you gave me a number for prevalence and false positive rate, which is around 5%, and the false negative, just about everyone agrees it's 25%. Okay? If you throw me a prevalence, I can calculate the likelihood that a positive PCR result is correct. And I'm telling you, it's really low.
Yeah, this is it's like standard Bayes rule calculation. Like what you end up with is if you have in a low prevalence environment, if you have even small false positive rates, overwhelms the test, so that the positive predictive value is really low.
Exactly. Now that's the person who's knowledgeable explaining it to someone who isn't. I don't know what Bayesian or whatever you said is, but I know how to calculate things when I'm given the information. And I'll tell you, let me just give you an example. I think it was if the prevalence was 1%, again, a low prevalence, the false positive rate is 5%, and the false negative rate is 25%, and those are all very reasonable numbers, then the likelihood that a positive test is correct, meaning that you really have it, is only 12%.
Yeah, I mean,
Isn't
the
that
positive predictive
amazing?
value really does depend on the prevalence. Of
On the
course, the prevalence will be
It
different
depends
depending
totally on the prevalence, huh?
on how the case rate is in the population, right? So if when the case rate is high, the positive predictive value is very high, much higher. When the case rate is lower, it'll be lower. Mass asymptomatic testing generally, because you're asymptomatic, that asymptomatic people are less likely to actually, prior probability of having disease is lower. And so there you're going to get a lower positive predictive value. I mean, you're right that the PCR test and the problems with it can exacerbate the problem.
Well,
I mean, I think this is a number that we won't. But you can't just multiply with the 0.25 to 25% versus, because it's all correlated with each other.
Oh, I know.
So,
I agree 100%. That's a really astute point you made there. Amazing, because I've written all these words here, but you're right. They're all connected together. The point, though, is you know that. Well, I'm going to show you a video in a second that really nails the coffin. But as far as these things that are connected together, these things are really significant. So first of all, a lot of the people that were called COVID deaths never had COVID. A lot of them that were called COVID deaths had it months ago and completely recovered, right? And that's why a broken leg was called a death from COVID, because they had a positive test. They weren't sick with COVID. They had no symptoms, but they were admitted to the hospital, tested, it was positive. Then they died of something completely different, but it was called a COVID death. Because I'm going to show you a video in a second where the director of the Illinois public health system tells you right off the bat exactly how they counted them, and it'll blow your mind. I mentioned it to you in the last part. You may not have seen the video, but it's only 30 seconds long, so I'm going to show it to you. Again, I would like to ask you this question, because you did the original seroprevalence study. What ratio of people who had symptoms or ratio of people who didn't have symptoms to had symptoms in your
it was about 30% of the people, I think. I don't remember the exact number, but it's about 30% of the people that had antibodies could not remember a single symptom from the long list of symptoms that characterize COVID.
Isn't that interesting? That's the percentage that I calculated had immunity in place. Boy, I sure would like for you to ask your colleagues if you think that has any credence at all. That idea that's why.
No, I think that has a lot to do with it. I completely agree with that.
But anyway, a large majority, well, not large, I guess it's 3 in 10, don't have symptoms, let alone death. But all those people would have been caused to COVID death if they died of anything else during the counting period. You see what I mean? See the problem? Yeah. It's enormous. But anyway, let's move on, because we.
No, I agree with this. I mean, I think we may never know the actual death numbers. It's hard to tell from the data systems are not set up to actually derive that. And part of it is just, there is this term of art, like what caused the death. When you have a death, when you have a disease like this that tends to kill older people with many chronic conditions, it's a difficult thing to determine what was the actual cause of death. It's going to be different. Doctors will do it differently, I think.
But I'm willing to concede all of those to being due to COVID. I'm willing to concede all of them. I'm talking about the ones that were impossible to be COVID. If you've never had COVID before in your life because you got a funky PCR test result, then you could not have died of COVID if you've never had it, right? So that's part of it. I mean, when you put these things in, I'm telling you, there's about 4 major factors that will lower the numerator. So when I calculated it to be 0.1% on the cruise ship, I think that's pretty accurate, because they hadn't, I don't know at that time what they used to measure whether people had it or not. But based on the numbers of the cruise ship, and knowing Japan the way they are, they might have sequenced everybody or something. You know what I mean? Who knows? But in the middle of the Midwest somewhere, or Texas or Florida, or I don't want to be biased against any state, those hospitals abused the system, I think, and called everything COVID. And the money was enormous in this. And I think they did it. Plus, there's things that people just don't understand. I mean, I'll give you a little funny story. I read somewhere in some article that they sent out a problem to 1,000 doctors, medical doctors, and it was this problem. You know, they gave the prevalence, the false positive and the false negative rate, and asked what were the chances that the positive diagnosis, when you go to the doctor and he says you're positive for COVID, what were the chances that it was wrong, that he gave you the wrong result? Only 4 doctors out of 1,000 got it right. And you and I just did it in our heads and got it right. But you know what I'm talking about, right?
I mean,
A lot of people don't understand this stuff.
It's not, the problem is like if people don't really have good intuition, even doctors don't have good intuition for this kind of thing. So like there's a famous problem in statistics that's related to this called the Monty Hall problem. I don't know if you ever heard of this.
Oh yeah, I've heard of it. Yeah, and that's easy. So easy, it's ridiculous though.
Well, I mean, like a lot of people get it wrong. Even mathematicians get this wrong. So like like just to tell people. So like the way in Monty Hall was a guest host for this, or was a host for this show called where what they would do is they would you'd have 3 doors, and the prize was behind one door, and the other 2 doors had nothing. And Monty would tell the contestant, look, which door is it behind? Of course, all the doors are closed. They don't know. They would pick one.
Yeah.
Then Monty would open one of the other doors where the prize wasn't.
Right.
Right. And then he'd say, if you want to switch, you're allowed to switch.
Yeah, obviously you should switch.
Right, because it turns out that the probability of it being in the other door that Monty didn't open is 2/3, whereas the one you picked was 1/3.
Sure, because it's
but a lot of mathematicians looking at this say, well, look, it's still there's nothing to be gained for switching.
Just to tell you a very simple way to look at it, though, the way I figured it out when someone asked me, at first, when there's 3 doors there, certainly the chance that you're going to get it right is 1 in 3. Would you agree?
Yeah.
So there's a 2 in 3 chance that it's behind the 2 that you didn't pick.
Correct.
And then Monty Hall eliminates one of them.
Yeah.
So it's got to be still 2/3.
It's got to be 2/3, right? And you can see this at the extreme. Like if there were 100 doors, one prize, you pick one door at random, 1 in 100 of being the right one.
So
and Monty opens 90. He opens up 98 other doors.
Oh yeah.
I mean, obviously you got to switch.
It's the same thing, same principle.
Yeah, but and this is related to this. This is Bayes' rule, right? So this says that in an environment where there's some false positives, even a low false positive rate, when it's very unlikely that someone has the disease in the first place because the prevalence is low, a positive test isn't a guarantee that you're actually positive. It's in fact, it's quite likely it's a false positive.
Right.
So it's just like the Monty Hall problem, actually.
Okay, yeah. So that's why you're saying the Monty Hall problem was hard for a lot of people, right? And
yeah, the intuition behind the Monty Hall problem is not obvious to a lot of people.
But 4 out of 1,000 doctors got this problem right that they sent out randomly. That was what the article was about how even the doctors don't understand this prevalence, specificity, all that stuff confuses everybody, according to the article. But yeah, we're in total agreement on all of this. I just think it's a bigger factor than you do. Maybe is that why we have a difference?
I just don't know the number. I mean, you might be right. You might very well be right. I just don't know what the number is.
Yeah, but even my point though is even if it's 50%, even if they doubled the deaths by all these horrible problems they have with it, that would have the IFR. Right.
Yeah, I mean, again, it depends on the country. I think I think John.
It depends on the country and also the situation. I really don't think the cruise ship that I calculated 0.12 from was very inaccurate in the deaths. I don't. I think it was pretty accurate. But I'll tell you, like again, in some little hospital out in the middle of Texas somewhere, they're calling everything COVID. Let me go to the next slide. You'll see what I mean. Watch this. This will blow your mind if you haven't seen this.
I just want to be clear in terms of the definition of people dying of COVID. So the case definition is very simplistic. It means at the time of death, it was a COVID positive diagnosis. So that means that if you were in hospice and had already been given, a few weeks to live, and then you also were found to have COVID, that would be counted as a COVID death. It means that if technically, even if you died of a clear alternate cause, but you had COVID at the same time, it's still listed as a COVID death. So everyone who's listed as a COVID death doesn't mean that that was the cause of the death, but they had COVID at the time of death. I hope that's helpful.
Doesn't that blow your mind to hear something like that from the director of public health for a state like Illinois?
It's crazy.
But
I think the argument that those folks made for doing this is it's related to this mass asymptomatic testing. They wanted to catch everybody who had it. They wanted to go find all their contacts and isolate them. They thought of this virus, this respiratory virus, as something that they could, like, if they just poured enough resources, they could find everyone, isolate them, and the disease would stop. And so they're like, okay, well, overcounting is not a problem, because yeah, fine, we find some people that we say are positive but don't actually have it. It's no big deal. That doesn't hurt our cause, which is just find everyone, isolate them. I think it's really just the question of like policy, right? They're counting for a purpose that's impossible, a utopian purpose.
They're trying to somehow conjure up a way to make zero COVID, which you cannot have.
Yeah.
You agree with that?
Yeah.
Zero COVID is a pie in the sky idea.
Utopian fantasy.
Absolutely. And that's why they wanted to test everyone, right? And trace and all this nonsense that didn't work even in January. It had already pervaded the population too much. And it doesn't take much before tracing doesn't work at all. Would you agree with that?
Yeah. In fact, I wrote a piece in July 2020 called "On the Futility of Contact Tracing."
Right.
I think the idea that you could use contact tracing to suppress this virus down to very low levels was just hubris on a massive scale. Massive.
And you know what's funny? The TV doctors, I don't want to name names too much, but I know who they are, and you probably do too if you watch CNN, because they kept coming on again and again, trying to tell us that the reason certain countries were doing well was because of testing and tracing.
Yeah.
And it wasn't the reason at all why they were doing well.
Yeah.
Part of the reason was they weren't counting everything as a COVID death because they weren't getting reasbursed for it.
Yeah. Well, that plus immunity in place. I think like
immunity in place. Absolutely. Yeah. That's part of it. But you see what I mean? I mean, these doctors are sitting there trying to say in August that we should be tracing more. And here's the amazing thing. Bill Gates is a very smart guy. He's very mathematical, very, very smart person. And he also thought tracing was a good idea really late, and testing. And I'm thinking, how did Bill Gates not see that? Because tracing is a little bit of a mathematical type of thing, with patterns and all that. He just missed it completely.
Well, I think there's an answer to this having to do with the mindset of a lot of these public health officials. A lot of them came up in the HIV era.
Yeah.
And their training and thinking is around HIV, and HIV contact tracing works.
Yeah, because it's completely different mode of transmission.
Exactly.
You have to exchange body fluids to get
HIV.
And
in HIV, you have when you get infected, there is no immunity to it. In fact, it destroys your immune system.
Right.
With HIV, you stop the spread by telling people to wear condoms. Just and the condoms actually do a pretty good job.
Yeah.
Not perfect, but it's a pretty good job. I mean, compared to masks, they transported a lot of their thinking from HIV to this disease without really deeply thinking through whether those
it's so work. Simple. HIV is very easy to contact trace because you know who you exchange body fluids with.
Yeah.
But when you're in a room and a lot of people have this thing and a lot of people don't, you don't even know half of them, you can't contact trace. You don't know who you got it from. You don't know who you got it from. You don't even know who you were in contact with when it's a respiratory transmitted virus, right? So they should never have made that mistake. To me, it seems very simple that they should have known that was
But
not.
a lot of them, I mean, I think they were copying each other, and they didn't really the differences between this virus and their usual toolkit. They didn't understand their toolkit. They just applied it mindlessly.
Right. Yeah, it was mindless. And that's why it shocks me that someone as mathematical as Bill Gates fell into the same trap. I've got a quote of his talking about, oh, we're not tracing enough and all this. It was late in the thing. Oh my God. All right. But isn't that an amazing video though?
I mean, that's just, it's hubris, Reed. It's hubris, is what it is.
Now, here's another thing in the lower left here, this thing over here, this just says there was a point on the 8th of August, 2020, when the CDC reported there were 149,192 deaths. And believe it or not, the number of COVID deaths with comorbidities, meaning other serious problems that could have caused the death, basically, was 145,378. So there were only 3,814 people who died with COVID alone. As in other words, is all they had was COVID. They didn't have any comorbidities. Now, I know this is very misleading also in the other direction because, you know, it's discounting people with saying people with comorbidities couldn't have died of the comorbidity is basically what this, or all would have died of it, couldn't have died of COVID. People with comorbidities had to die of the comorbidity. That's sort of what this is saying, which is equally messed up in the other direction. But it does give you a sense that, I'll tell you, there's a lot of misrepresenting going on for money.
I mean, the key thing here is like, this is a respiratory disease. It's a coronavirus respiratory disease. It's more severe than the existing ones, but it acts like it, right? So the other coronaviruses, who does it kill? It kills people that are older with lots of comorbidities.
Absolutely.
At the end of your life, I mean, this thing essentially, if you're young and healthy, you react, you'll get a cold, or you get, it's not likely to do a severe damage to you.
Right.
You might even produce no symptoms at all, like we said, 30% of the time. Whereas like if you're older with lots of comorbidities, you're actually at high risk from this thing.
Absolutely.
So I think that clinical nuance, which seems so obvious in the context of this panic, just got lost, as if everyone is equally at risk. Actually, they did this with HIV too. You remember during HIV, the question was who's passing it to who is, and in the US and the West, it was primarily homosexuals and people with people who had IV drug use. Those were the two main groups that had it. But the messaging was, well, everyone needs to use a condom. Everyone's equally at risk.
Right.
In HIV.
But there were reasons why they did that. I've thought about this a little bit because I wondered why that was so messed up. They had to sell to Congress that it was a heterosexual disease also to help them get more funding. That's what I read. So
I mean, I'm not even, I don't want to go into like whether it was right or wrong to do that in HIV.
I know.
I'll grant you that. I'll grant you that there were reasons, but I'll say in the context of COVID, it was a huge mistake.
Oh, absolutely.
Right, because what it did is it elevated the risk relative to other risks in people's lives, in the minds of people, even who were at low risk, and so we ended up closing schools on the basis of it. And actually, I think it probably made old people who actually did face a very high risk, some of them probably underestimated the risk relative to the true risk. If the gradient is like this and everyone thinks equally at risk, the people truly at risk underestimate, the people not at risk overestimate, and bad results happen all the way across.
Agree 100%. But didn't we know from the Wuhan data that it was an old person's problem?
Yeah, we did.
All right. And we also, that was reinforced, and Wuhan happened before us, obviously. What reinforced it was when it got to the United States and they started publicizing the people that were dying. I remember like it was yesterday. It was a nursing home in Washington State, was where the first sort of cluster of people died, in a nursing home. So there was never a time when people shouldn't have known that it was an old person's problem. Is that true?
But the public health messaging, including this business with the deaths, like the idea was we need to make sure everyone takes this virus very seriously so that they comply with public health orders.
Yeah. And could that be possibly why they tried to gin up the fear?
Yeah.
People take it seriously?
Yeah, that's
really
exactly why they did that.
Problem for certain people, let's face it.
I mean, this was a policy decision. What this little video is a policy decision. If they were to count deaths the way they normally would count deaths and cause of death, they would have had much smaller numbers. They would have had less ability to point to a number and say, look, we should be scared of it.
Yeah, but I'll tell you why this stuff is so. I'm not telling you anything. Believe me, I didn't mean to say it that way.
No, John DeVries.
Just the way I
fun
talk.
to talk
I'm
with you.
sorry, but the reason this is of jugular importance is because if people had known before Trump and these guys start talking about putting them in lockdowns that the IFR was lower than the flu, they would have said no way. They would not have agreed to the lockdowns. So these guys, these epidemiologists that said it was 4% or 7 or 2.8 or whatever percent they were saying, they were all a little different, but I'm talking about the CDC and the WHO, they thought it was 4%, the IFR, the infection fatality rate. So people can quickly multiply 4% times 350 million and think 14 million people are going to die. But actually the infection fatality rate was really, and again, we have a difference here, but when you figure the numerator wasn't right either, I'm telling you, it's low. It's right down there with the flu.
Yeah, but again,
So
I think the key
people would have said, "What do you mean you're going to lock us down for something that's the same as the flu?"
The key thing is not that number. The key thing is not the average or median across of like the infection fatality rate. And you might be right about. I mean, you are right about the numerator, and we of course we agree on the denominator.
Yeah.
The key thing is the age gradient.
Absolutely.
So
but
because
remember,
the
they
age
had to
gradient,
sell the lockdowns to all ages, though, so they had to scare everybody.
yeah,
If they had done what you guys proposed from the beginning, God, it's
yeah, which is what they
hurtful
should
to
have
think
done.
about what they would have saved in human suffering, because
Completely agree.
the answer was to do exactly what you guys said in the Great Barrington Declaration. That was exactly what they should have done from the beginning. This virus was so mild in the working class that they should have gone about their business, just like they go about their business for the flu every year. No difference, really, right?
Yeah, and they could, but they could have, and of course, devoted a lot of resources and more thought to protecting the vulnerable.
Right.
I mean, look, we take New York, right? So why did they send COVID-infected patients back to nursing homes? It's because they had the wrong idea about who was at risk for the disease. They thought that they needed to protect hospital systems from getting overwhelmed. That's why
never happened.
Right. In New York, there was like the Mercy ship. There was all kinds of like resources available they didn't use. But the key thing was the thinking. The thinking was what was at risk was hospital system overwhelming. That was the risk they wanted to mitigate.
They were totally wrong.
Instead of trying to protect the vulnerable. That was the real thing that was at risk.
Right.
If they had in their head that the older population is truly the big group that's at risk, they would never have sent any patient back to infected patients back to nursing home.
Right.
That was the category error.
I agree. The alternative that they thought was the problem, like you said, was jamming the hospitals with too many patients. Those Mercy ships hardly got any patients. They turned around and left after a week.
Correct. Yeah.
And in Texas, they built all these tents everywhere around the hospitals to take overflow, and they tore them down and were never used. So the overflow thing was a lot of bunk. I hate to say it that way because, as you know, hospitals try to keep their ICUs about 80% full, 80 or 90% full all the time because they're so expensive to have those well-trained nurses there when the beds are empty. It costs them a lot of money. And so they try to keep their ICU beds at near capacity all the time anyway, right? So when someone gets on TV and says, "Oh wow, the hospital, the ICU beds in Nevada are 80 or 90% full now," they're always 90% full. You know what I mean?
I mean, so there's a website that the Health and Human Services in the U.S. put together called HHS Protect, that and they set up a system to track. Sort of what fraction, how many beds are available in different states and different locations. I was tracking that through a lot of 2020 and through in 2021. I mean, I think I saw like in the winter of 2020, there was maybe New Mexico, I think was over 100%. These things are systems too, right? So one hospital being pushed is not the same thing as the system is overwhelmed. You transfer a patient to a different hospital.
Sure, of course.
I mean, it's the U.S. was fortunate. I mean, there were places where the hospitals were overwhelmed. I mean, Italy in 2020, in February 2020, was absolutely overwhelmed. No question. Sometimes in Spain they're overwhelmed. But I think the U.S. was actually quite fortunate in that it had it was pushed, but it wasn't overwhelmed.
Right. But so if you look at a rich country like the United States, they're going to have way more ICU beds per population than a very poor country. Would you agree with that?
Well, it's funny. It actually varies. So, for instance, like Japan has way more ICU beds and hospital beds per capita than the U.S. does. The U.S., the number of hospitals have actually been declining over time because what's happened is a shift from management of patients inpatient to outpatient. It's been going on for decades.
Yeah. Which you think would help, but it's actually closed hospitals. Okay.
Yeah, but you still have tremendous hospital capacity in the U.S. and the idea that for most of the pandemic it was overwhelmed is just false. For most of the pandemic, it wasn't. There were some times where they were pushed.
Well, that's absolutely what I'm saying. The principle that they used in their mind to send the people back to the nursing home because they were worried about the hospitals overflowing was wrong. That's all I'm trying to say.
Yes.
The hospital problem was not the problem. It was the age gradient.
Yeah.
True?
Exactly.
Okay.
We
So,
completely agree on that.
There you go. You know, that was a real big mistake. It didn't only happen in New York either. I heard there were 5 governors that did this. Michigan,
yeah, I mean,
New
it was
Jersey,
Pennsylvania. It happened in New Jersey. It happened. I mean, in a whole bunch of states. Wisconsin, I think, was another one. But it wasn't just the U.S. This happened in Stockholm in the early days.
They botched their nursing home stuff too.
Yeah, and in Quebec, it was even worse. I don't know if you know about this, Reed, but in Quebec, the workers in the nursing homes actually abandoned the nursing homes, leaving patients with dementia to die of starvation and thirst.
Oh my God! And where?
In Quebec.
Quebec, Canada. Okay.
Wow.
Yeah. I mean, again, it's the situation where the government fudged a lot of numbers. Let's face it. They wanted to maintain the fear, maybe out of for a good reason, and that is to make everybody careful about what they were doing. But they caused these nursing home employees to abandon it by scaring the 23-year-old lady that works in the nursing home, who has almost no chance of dying from it, right? Just like the flu, let's say.
Yeah.
And they scared her though, and that's why she abandoned the nursing home. See all the damage that's done by these. If they would just be honest with the people and tell them exactly what the truth is, and not try to scare them when there's no reason to be scared. Let's face it. There's no reason to scare a 14-year-old girl about this. She's not going to get sick from it. You know what I mean? But they inflated all these. They were calling things new cases when someone got a positive PCR test, and all it measures for is RNA, which means the patient could have recovered 2 months ago, and they were calling it a new case on television every day. See what I mean? Okay.
I mean, we agree on this, obviously.
Yeah, we do. So anyway, I made this little thing here where we were going to put a % down for each thing. And the number, the Alameda County number, which we talked about, would have been 0.75. But when you put in these other things because of the PCR, I tell you, that thing drops fast. So let's go on to herd immunity, which is another thing to me that blows my mind, because I see medical, even public health people on television talking about herd immunity, and it's crystal clear they don't understand what herd immunity is. I saw one guy from England or somewhere, I think, who was talking about herd immunity being equivalent to no one getting COVID. I think he said, you know, or it was implied from what he said. And I'm thinking, oh, how could this guy not?
It's not just one guy, Reed. That is very common. Like a lot of people, even doctors, have used herd immunity as a synonym for zero COVID.
Oh, and also mass murder. Wait till you see some of the quotes I show you in a second.
Yeah.
But
No,
anyway, let's talk about what we have. We'll get to the slides later. So herd immunity, please jump in. Is it not when the R value is less than or equal to 1? That's
so it'd
when
be
you have
RT is
immunity.
less than 1, not R not
No,
not
I
less
don't know
than.
what I don't even know what R means, but people keep.
Oh, okay. So
R.
let me describe to the
They're not
audience. So
R not. It's the R with time is less than or equal to 1. I shouldn't have put not
yes.
there. Yeah. Okay. But the point is it's where the derivative of the infection versus time is 0. It's the maximum of the Gompart's curve. That's when you hit herd immunity. Would you
Yeah.
agree with that?
So the definition of herd immunity is, so let me just describe the context. Okay. So because this is very important. This is in the context of a compartment model. A compartment model, the simplest version of the compartment model, you have a susceptible compartment, a group of people who are susceptible to disease, that they don't have immunity in place, or they're immune naive or whatever. You have an infected compartment, S for susceptible, I for infected, and then that is people who are actively currently have the disease. And this is used for measles, it's used for a whole bunch of diseases. And then there's a recovered compartment. Now there are like variations on this, so there's like, for instance, there's one version that's used commonly in COVID where you have an exposed compartment. So there's a whole, and you can like make it more detailed. You can have old people are susceptible, young people susceptible, but in the most simplest version, SIR, 3 compartments. People transition between compartments at some rate. You go from S to I. S meaning you're susceptible, you become infected. And the rate at which people become infected depends on how many people are in the infected compartment.
And how many people are in the vulnerable compartment, right?
Well, in the S compartment, right? So the rate at which people transition from S to I in simplest versions of the model depend on mainly on how many infected there are. But it also depends on how much interaction there is between people in the population. And again, the simplest versions of the model, every person in the population randomly can interact with any other person in the population. That's not true for actual human societies, but that's in the model.
Yeah.
And so you have a model where over time people transition from S to I. Some of them recover, some of them die, and you end up with you get a dynamics in this model of how a disease propagates through a population in the context of this model.
Right.
R0 is the number of people.
Yeah, I'm sorry about putting the not there. Go ahead.
Oh, no problem.
Yeah.
So R0 is the number of people that when there's one infected person, how many people does that infected person infect?
Sure.
So a large R0 number means that one infected, it's a very infectious disease. One person infected infects many other people.
It could be like 7 or something for measles.
Yeah, that would be crazy high, right? So it's a very high number. So the thing is, in the context of those models, if you run the model all the way through over time, people are going to go from S to I. That susceptible compartment will get smaller and smaller over time.
Right. Yeah.
And the reason is that they're infected and then recovered, or they die. And so it'll shrink over time
because they become part of the herd, right?
Yeah. Now at the same time, a lot of the people that are infected it'll grow and then it'll shrink, because a lot of the infected people will become recovered.
Right. Yes.
And when you have then a random interaction between people in population, it'll be very likely between a recovered person and a susceptible person, or an infected person and a recovered person.
Right.
Not between. The only interaction that results in a transmission is between an infected person and a susceptible person.
Right.
At the beginning of time, at the beginning of this model, all of the interactions that are happening are between susceptible people or between susceptible and infected people. As the fraction of the population that's recovered grows, those random interactions are less likely to produce an infection.
Right. And
that's what herd immunity
reaches the point where the R value is equal or less than 1, then you've got herd immunity. Because herd immunity is what I just said. Herd immunity is the fact that when a large fraction of the population is in the recovered bin, the random interactions are unlikely to produce a transmission. The herd immunity threshold is defined the way you just defined it. It's the number of people in the recovered bin, if you will, that such that the random interaction where one infected person interacts with someone in the population
on net will produce one or fewer additional infections.
That's
That's the
what I
herd.
mean.
That's the herd immunity threshold is defined that way.
That's what I mean
Yes.
by this.
Yes. So that's not. So the reason I push back a little bit is that's not herd immunity. That's the definition of the herd immunity threshold mathematically.
What you have
so
to
herd immunity
reach
happens
when
even-
you have herd immunity, though, right?
Well,
In
so-
other words, you have to reach the infection, the derivative of the infection to time.
So you read the way to think about this is that herd immunity happens almost from the beginning. As soon as you have a single recovered person, that person contributes to a reduction in the spread of the disease in the population.
Yeah, exactly.
Now, the herd immunity threshold is defined such that when there's that random interaction taking place, the newly infected person infects one or fewer additional people. That's
Right.
a threshold definition. That's not saying that we've reached. I mean, that just means that the disease, as you say, the derivative goes negative, right? That you start to see
Yeah.
a decrease in the number of infected people, or
Right.
zero, like there's no change in the number of infected people because every additional person infects one or fewer additional people. If they infect less than one person, then the disease will decline in prevalence over time.
Right.
So-
So it's the downside of the Gompertz curve.
Yes, well, it's not exactly Gompertz in generally. It depends on your assumptions about mixing, but yeah, there's the downside of the up and the down of the curve.
Yeah, okay. What I mean about an abstract concept, let me just give you an example. It doesn't just apply to infectious diseases at all, herd immunity. For example, I don't own a gun, right? I don't want to own a gun in my house, but a lot of my neighbors own guns, of course, in Florida, right? They have guns in their house. And if a thief is trying to figure out which house to rob, might be a little afraid to rob my house because he knows in this area a lot of people own guns. So in a way, I'm protected by the herd of my neighbors who own guns and have them in their house. I'm protected from that thief. You follow me?
Yeah.
So I'm protected by the herd of the houses around me where they have a gun in the house, because that thief does not want to get shot.
Yeah. So I mean, I
See
think
what I
it's
mean?
like the thief doesn't know who owns the guns,
Right.
and so
But the
they
fact
won't
that
come to your
there's a lot
neighborhood.
of guns and having a gun in your house is legal. Those neighbors protect me by herd immunity. Now,
Yeah. So the difference, of course, is that it's not infectious, right? So you don't hear the act of someone recovering from the disease because they are immune from the disease or less likely to get to spread the disease. That itself is what protects you, right? So
exactly. Yeah, when the people that are susceptible get infected by the group that has the disease and can infect people still, that person will become part of the herd. He'll jump into the group that's in the herd because he now will have antibodies to it or die. He'll either die or become part of the herd, right? Because once he has antibodies, he can't get sick enough to pass it on to the next person. Correct?
Okay, so that's in a simple version of the model. So I think one of the key things here is that that simplest version of the model isn't exactly the right version for COVID, and the reason is because of the variants. The variants make you susceptible again.
Right. Yeah. Oh, yeah. But then if you really want to be strict about it, could you say that, and this applies to vaccination too, right? Because as soon as there's enough mutations to where the lock and key doesn't work anymore, if you know what I mean, between the antibodies and the antigens, then you can get it again for sure.
So yeah, so now it's the antibodies. Now it's not just the antibodies also, and this is the key point. If you had COVID and recovered, or if you have the vaccine, it produces an immune reaction such that even for future variants, it seems like you are protected against severe disease. You're likely to get a milder version of it if you'd had the original version of it and then later get Delta, you're gonna get a milder version of it. So for instance, just like I said in that study out of Italy, where 1 year after COVID recovery, they've tracked this cohort of people that had COVID for certain, and there was 0.3% reinfection, and among that 0.3%, only one was hospitalized.
Okay, so could I just throw in one thing? Herd immunity, though, is about spread. It's not about the severity of the disease, right?
No, it's about population immunity. So population protection against the disease. So in this very simplest versions of these models, it's just about spread. The question the way I think about this is immune naivete versus immune sort of broad protection, right? So for instance, a population today, 2 years after March 2020, we're recording April 2022, has much of the population, either through the vaccine or through recovery from infection, has protection against severe disease from this. The disease will continue to spread. The disease does not have neutralizing immunity against all potential variants. There's going to be another variant.
Yes.
And it'll spread, but it poses much less of a threat per person because much of the population has seen the disease before, or because they've had the vaccine. That's a form of herd immunity, in a sense, right? So it's not going to kill you if you get it. So in a sense, like, you could we did that compartment model, SIR. Well, you could also do a fourth compartment. You could say S completely immune naive, R completely, you neutralizing so that you're not going to ever get infected, and then R, you were susceptible again, but you're not likely to be severely infected, get severe disease.
Right, but in that second group, the new group that you put in, that has to do with the variants are getting further and further away from the original to which you got immune memory for.
Yeah. So there's one other complication, Reed, and I think that over time, your antibody response actually sort of fades, right? So if you had the disease after a certain number of months, you won't be able to detect antibodies anymore.
Yeah, but that's another thing I bring up later. All antibodies are molecules in your blood, and they're gonna wane with time, like any molecule in the body.
And so you then will be, you no longer have circulating antibodies. You could get infected again.
But you have clonal memory. You have B cells that have
So you'll get a mild
memory arm.
You'll get a mild infection.
Or you'll get, well, when you say mild infection, you mean no symptoms, or you mean
you have a mild cold. You might have mild symptoms. Because basically firing up your immune memory to deal with the thing is an infection. But it's not one that's likely to produce a very severe outcome, unless you're old.
Yeah. Okay.
Or with lots of chronic diseases.
I think we're really splitting hairs there, but I'm saying, like, you've got.
No, so I don't think it's splitting hairs, Reed. I'll tell you why. The mistake that a lot of people make here, and it's you can see it in this mass murder thing. I mean, the people don't, or what we were talking about before.
Yeah.
Thinking of herd immunity as it's gone. That's not true, right? What the disease is not. It's not the kind of immunity that's produced by a coronavirus infection is not the same as the kind of immunity that's produced by, measles or something. If you get measles or you have the vaccine against measles, you're not going to get the disease again.
Right.
Even
if you get someone with measles that breathes in your face for 17 hours, you're not going to get measles again because you have clonal memory to it.
Yeah.
You don't have the antibodies in your blood anymore.
That kind of immunity it doesn't happen with coronaviruses. That kind of immunity does not happen with coronavirus. With coronaviruses, you have that kind of immunity lasts for a few months, maybe 5, 6, 7, 8, 9 months, and that's why you saw 0.3% in that Italian study. But at the same time, you have quite good protection against severe disease.
Okay. Let's hash that out. That's very important, really important. Yes, I understand this point about severe disease. I'll tell you, we're gonna talk about that a lot in a second, but everybody loses the molecules, the antibody molecules with time. Would you agree with
Yes.
that? In other words, you don't have the antibodies in your blood anymore from when you got vaccinated for the measles. They're long
Yeah.
gone, but you have clonal expansion for memory. So that
Yeah,
when
so-
another measles virus gets in you, those B cells that are clonal memory for that antigen, for that epitope, will differentiate into plasma cells immediately, and they will start pumping out antibodies like nobody's business, and they will go and they will kill that measles virus particle that got in your body. You
Yeah.
don't need
I mean,
antibodies in your blood anymore.
What I'm saying is I think that kind of very efficient neutralizing capacity, which lasts for a very long time with measles, doesn't last forever with coronaviruses.
Even
like
if you get the
OC43.
disease and it doesn't mutate.
Yeah.
Really? I mean,
Yeah, I think so.
that shocks me. That's something where we do finally, after all this time, really fundamentally disagree.
Well, I
think
mean, I don't-
those point
I
three.
guess, what does this mean to be sick? Like, I guess that's what it comes down to. Like, if you have the sniffles from the second time you get OC43,
What's
are you
that?
sick?
Is that
Oh,
COVID?
like that's a human. That's one of the human coronaviruses, OC43.
Okay. All right. You mean
Right?
that caused the cold or whatever?
Yeah, it causes
Okay.
a cold.
Yeah.
So you got OC43 when you're a baby.
Yeah.
You caused the cold.
Yeah.
Then, because you had immune memory to it, it didn't protect. It wasn't complete, but you got it later. A few years later, you got it. You were exposed and got it, another cold.
Another OC43 exactly?
No, there's not. Maybe not exactly, but
Well,
because there's mutations.
That's where I make a big distinction, because then the antibodies are not that good at neutralizing it anymore, because the antigens aren't the same on the spike proteins. They've changed.
I mean, I guess the thing is so remember the Italian study, right? Because that's 0.3%. Who are those 0.3%?
Get
Yes.
reinfected. Well, I'm against that anyway, but go ahead.
But I think that 0.3%, it's because it's both the virus and the host, right? So maybe the host has some immune issues that led to essentially being susceptible to be reinfected. So you don't mount the same response.
I'll give you that. If they have I'm talking about immune healthy machines.
Yeah, I'm talking about the population at large. I mean, the population at large includes both, right?
Okay.
So and so I think what
That's
you see
why
over
old people
time,
get hit harder with it. One of the reasons.
yeah. So you, I think,
Okay.
from a theoretical point of view, in the population at large, let's say 90% of the population gets exposed and most of them recover. Over time, that the percent susceptible will grow.
Yes, true.
They'll go from now it won't. I don't think it's fast because it's again 0.3% at 1 year, but I think it will grow. Even again, this is without variance. One other complication here that's really important: the herd immunity threshold.
Can I just throw this in real fast? I don't think immunity from getting the disease and recovering wanes that fast. I just don't believe it.
I mean, I get if you have some immune issues, you do agree.
Immune issues, that's different.
Yeah. So I'm talking in a population. In a population, there'll be some subset. Yeah.
All right.
So now, well, there's one other really important complication here that's really, really important here that has to do with the herd immunity threshold. So we've defined it as there's a famous formula. It's 1/1 minus R naught. That's the herd immunity threshold in this SIR model, the simplest SIR model, right? So that's the fraction of the population that has to be infected until the disease starts to go down. There'll be now if you run the disease to infinity, time to infinity, you'll get a compartment of people who are never infected. You get a group of people who are never infected.
Okay.
And it's related to the herd immunity threshold. The key thing here is that the herd immunity threshold can vary with seasons. So in the summer,
that makes
or
sense.
in some certain environments, the disease just doesn't spread very efficiently. You have two people that randomly interact with each other, one infected, one not, that the disease just won't spread. Whereas in the winter, it's even a short interaction can lead to the spread of the disease.
Yes. I agree
And so
with
the
that.
herd immunity threshold then is not a single number,
Right.
1 over 1 minus R naught. In a more complicated model, the herd immunity threshold will vary over time.
Yes.
It'll be
I agree
high.
with that. Yeah.
It'll be very high during when COVID is in season, and it'll be low when it's out of season.
Yeah.
And so what that means is that a very large fraction of the population needs to be in the recovered component when the herd immunity threshold is high for the disease not to spread.
Right. I agree.
Right? So that's why in the winter it spreads, because the fraction that are in the R compartment is lower than the threshold. When it's out of season, the herd immunity threshold then drops, and so you can have the same fraction in the R compartment, but the disease just won't spread because the herd immunity threshold is below.
Yeah, and that puts lower cases in the summer, for example.
Yeah.
Makes perfect sense to me what you said. I agree 100%.
And so you can get these like very interesting dynamics in these models where if the fraction that are susceptible increases over time, the fraction immune decreases over time for whatever reason.
Yeah.
You can get a place where, like, so for instance, New York has an enormous wave of cases at the beginning of the pandemic, and then they see no cases for a very long time.
Yeah.
Until finally the fraction of the population susceptible comes back. Now, what a variant does is it just resets the model. In one sense, right? It makes,
yeah, but it's got to be a variant that is significantly different enough to truly.
So Omicron is a good example of this. It takes a lot of people that were in the R bucket that were relatively immune from reinfection and puts them back into the S bucket, but they're not actually immune naive. They still have that cross protection. So that this is partly why Omicron's less deadly, is because it's reinfecting people who recovered from either Delta or Alpha or the original variant.
I agree with that, because so remember, there are some proteins in Omicron that are the same as they were in the wild.
Even the spike, okay, there's a lot of different mutations, but even the anti-spike protein, the antibodies and spike protein from the original variant still actually do quite well. It doesn't neutralize, but it reduces the harm from Omicron infection.
I'll tell you though, a problem with that though, and that is when you have antibodies that aren't good enough to neutralize the virus, and they stick to it weakly, and you've got macrophages around that have FC receptors on their surface, you get a thing called antibody dependent enhancement.
You can in theory. I mean, I know about this, right? But the thing is I don't think we see that in the epidemiological data, because if that were true, then Omicron should have been more severe for the people that were previously infected, or also who had the vaccine. But they're not. It's not. Well, it's not more severe.
What it'll tell you is that it will. I mean, have you studied this epidemiologically for like dengue fever?
Yeah, for dengue is a very different case. Dengue, you get antibody-dependent enhancement. That's very clear. Okay. But that's not true here. You don't see it in the epidemiological data here. Okay. A lot of people worried about it, but it has not showed up, in my view, in the epidemiologic data to date.
The only thing I would say is, I'll tell you, when you look at the vaccine data recently, and you think about it in the context of the recent release of material, remember, it had this big fight between the FDA wanting to keep it quiet or keep it locked away for 70 years, and the judge makes them release it. What's in the most recent release, as I understand it, is that for 1 week after you get the first shot, it actually damages your immune system. The white counts of everybody drop.
That's true for. It's true for 2 weeks, from what I understand, but that was true before that was true prior to Omicron also.
Oh, I know. I'm not saying that it's why Omicron is weaker. I think there's a few reasons why Omicron is weaker and spreads faster.
The key difference, the most important difference, is that the population is not immune naive. Both the vaccine and prior recovery from prior infection from the other variants provides protection against Omicron. It doesn't neutralize it, but it makes the disease less severe.
Okay, can I just throw one idea in your head to justify on that? You know, the flu, has the same issue going on. I mean, there's differences in the antigens every year. That's why the flu shot changes every year, right?
Yes.
But have we had a steadily decreasing number of deaths in the flu because of the thing that you're talking about? It's about the same every year.
The flu is so different in how it in how it mutates, right? So it's tailor made to mutate in a strange way. It's like it evades prior immunity to other like if H5N1 antibodies are going to have very different you're going to have very different, like that won't provide a ton of protection against H1N1.
All right, so let's forget that then for a second, because
right. So the flu is not the right model for this. The other right model for this is the other coronaviruses.
Okay.
So if you have an OC43 infection and then you have a mutated version later on for the OC43, you are going to get, it's going to be mild the next time you get it.
I agree, but isn't that because some of the antigens, some of the epitopes in the original ON43 don't change, even though it's a new variant?
Yeah, that's the same thing here, right? This is what I'm trying to say. So like the COVID is not that different in that sense from the other coronaviruses. I think the long run of COVID is that it's just going to be another circulating coronavirus.
Absolutely, it'll be like the cold, no question about it.
And the reason is because of this, the way that the immune memory works. It's not going to be neutralizing for your lifetime. It'll be neutralizing for a little while, but then when you get it again, it'll be mild because you remember how to deal with it.
Yeah, I agree. I mean, your body remembers.
Yeah,
that we're saying the same thing. The only difference we have is when the thing does not change at all. I don't think you can get it again until you become weak immunologically. Like, old people certainly have weaker immune systems than a fit 30-year-old, right?
Yeah.
So then they can get something again. But a fit 30-year-old can't get it again until his immune system starts to weaken, in my opinion. But the Italy data contradicts me there.
No, I don't think it contradicts. Because I don't know who those 0.3% are. It could be that they've had some immune function shortfalls.
Oh, then I agree with it. Then back to my theory. That's why
because we just don't. I mean, this is the population data.
Healthy immunologically.
I mean, I think I'd say that I don't know for certain what you're saying is right, but it makes some logical sense. I would want to see more work to see exactly who those 0.3% are.
Yeah. Okay. We would like to know that though. But yeah. I think we're kind of arguing the same thing. I'm just real rigid about the variants are surviving better because they're a little, let's put it this way. The variants, you can re-get COVID. You can certainly re-get Omicron if you had the wild type. It's changed so much that the antibodies you made for the wild type do not sufficiently kill Omicron. You will still get sick from it. It'll be a much weaker illness. We both agree on that.
Yeah, I mean, you're less likely to get sick.
But if the wild type had never changed, unless your immune system got weaker, people would not be getting it again. It would be just like the measles. I mean, think of chicken pox and shingles. That's a really good example. I do surgery.
Well, shingles, yeah. So shingles, you get it's reactivated chickenpox. It's literally the same virus.
Right, but if you're immunocompromised, you will get shingles much easier than if you're not.
Yeah, that's true. But even non-immunocompromised people can get shingles. I mean, that definitely happens.
Oh, I know, but I'm just saying it's more common in immunocompromised people. That's why old people get shingles.
But it's not zeros. I mean, I thought we were talking about zero, right? So in the shingles is a good example of this. So you definitely, you're right, immunocompromised. So like for listeners, when you were little and you got chicken pox, that virus never went away from your body. That virus sits in your dorsal nerve roots, which is like basically in your spine, and dormant for most of your life. Shingles is a reactivation of that same chickenpox virus later in your life,
right?
And it is more likely to happen. Shingles happens. It looks like chickenpox, except it's across the spread of the dorsal nerve root that it's sitting in.
It's in the dermatome of the dorsal root ganglion that lives in. So it comes right out. It only does half your body, all that stuff.
The dermatome was the word I was looking for. I was missing it. But yeah, so you
like you get a stripe on your chest that stops it halfway because that's where that nerve goes. That's what it
Right.
innervates, the dermatome for that dorsal root ganglion. Where
right.
it lives. Yeah.
And the key thing there is that mostly it's people that are that have some immune dysfunction that were reactive. This is not only. There are a lot of people who don't have a particular. I mean, you could go through a period if you're stressed, for instance.
Yeah, sure. But stress will reduce your immune system, though.
Yeah, right, exactly, like glucocorticoid reductions, immune function.
Sure.
But I think that the point is like they're not immune. They're not like immunodeficient. They're not permanently immunodeficient. Just you have some reduction in immune function for whatever
right.
reason.
Yeah, it can be short term. Yeah, sure.
Yeah,
Like
at that time you're exposed to COVID again, and you get that same variant, and it just reinfects you. It can happen.
What? Oh, okay, that's interesting. But that's where the analogy breaks down for me because COVID doesn't live in your body like chickenpox does.
No, of course not. But if you get exposed to the same variant again later during that year, you happen to be in a down point in your immune
you
function.
You can get it again. Sure,
you're stressed
absolutely.
or whatever.
I agree.
Then you can get it again.
Yeah, I agree. Yeah.
And that's where you get the 0.3 maybe.
It could be. I mean, there's something about that 0.3 that's telling me that their immune system is not working at optimum performance. Otherwise, people wouldn't get it again.
But when you think about COVID in a population level, of course we have to save those people. Those people are important too, of course, right? So you shouldn't say,
of course. Oh, absolutely. Yeah. But
so we shouldn't say it's zero. It's just we should say it is what it is. And then when there's a variant that comes along that's significantly different, like Omicron, it resets it. But it doesn't, like, it sounds scary to people that it says it resets it, but it doesn't reset it to zero. What it does is you're now you can get it again, but you get it and it's likely to be much less severe because you have had that recovery from prior infection or the vaccine. Yeah.
In other words, all these coronaviruses that are the cold now might have been much worse a long time ago.
There's some evidence like OC43. The theory is that it entered human circulation in the 1890s in this massive epidemic that hit Russia, it took. We didn't have PCR then. We didn't have any way to track it then. But that's the theory, and that over time it became endemic in the population, such that now it's one of the circulating coronaviruses causes common colds.
Yeah, which
first get it when you're little.
Will be someday too, I think, right?
Yeah, and I don't think it's just variants that did this. I think it's immune protection provided by in the context of OC43 by prior infection. So OC43, a lot of kids got it when it first entered. Those kids, when they got it a second time, didn't get a severe disease. And they got it over and over again until then when they were old, they got it and it killed them.
When they were real old.
When they're real old, or their immune function dropped to whatever. I mean,
yes, correct. So the immune function as you age, especially when you get up like 80 years old, it really drops off a lot.
Yeah.
I don't know if I told you this or not, but I do surgery on children here that are poor, and a lot of them have AIDS because their parents died of AIDS and they're in orphanages now. They have no money, so I do it free, right? And I'll get busloads of kids with HIV, and they all have zoster on them because their immune system is wrecked from the HIV, right? Because the HIV virus lives in the T helper cells. So their immune systems are very weak.
Reed, you're a good man.
Forget it. Thank you. But anyway, so we get a busload of them, and it's the worst ones, I'll tell you. When it gets the ophthalmic division of the trigeminal nerve, the shingles is in their eye. Talk about painful. It's bad enough on your leg or your abdomen. Ooh. These kids get them on their face all the time for some reason. But anyway, so yeah, we're talking about the same thing. I'm just a real black and white person on this stuff. If the person's not immunocompromised and the disease does not, and the virus does not mutate, you're not going to get it again because you're.
So actually, what can I just? I have to go very soon, so let me we can like pick this up. But I would like, but I just want to like wrap this up because I want to like make sure people understand the link between herd immunity and immunity is like this close. It's this close, right? So the kind of immunity that infection and recovery provides or vaccine provides determines what herd immunity actually means. If you have a very simple thing that fits the simple model of herd immunity, then what herd immunity means is you're going to have a fraction, some part of the population that's going to be protected most of its life from it, simply because everyone else got it and recovered.
Yeah.
Here, what you have is a setting where, like, you could protect some fraction of the population from getting it, in principle, at least, until a vaccine or some other mechanism of treating it. But the way that the immunity produced by COVID infection and recovery is such that it's not, because of the variants, it's not going to be permanent.
Right. I agree.
And so
100%.
herd immunity is not a synonym for zero COVID.
Absolutely
herd immunity,
not.
And it's also not even a like sometimes people say herd immunity is a strategy. That's just ignorant.
Yeah.
Herd immunity is just a biological fact that comes out of the fact that when you have a lot of people in that recovered component, random interactions between people are less likely to have the disease being transferred from one person to another.
That's correct.
It's just a biological fact.
Herd immunity is a good thing.
Yeah, it's a good thing, right?
Always. So
yeah, exactly. So it's a very strange thing to see people take this basic biological fact, which does protect human populations from many, many diseases.
Oh yeah.
And turn it into this boogeyman.
Oh, it's horrible.
Like a strategy. It's like it was essentially a way to justify lockdowns, which was a utopian idea. Like the idea was the implicit promise was, well, if we just do these strategies, you'll stop the disease from spreading and it will get to zero and everyone will be protected. That was a lie. A lot of the demonization of the concept itself of herd immunity was a kind of propaganda.
Right. Absolutely. It's what the people that were against the Great Barrington Declaration used by calling it mass murder or let it rip or whatever they lied about.
Yeah.
Describing
exactly.
it. They incorrectly characterized it with those kind of phrases. Yeah. And you understand, I'm sure you.
I lived it. I mean, we can talk. Maybe next time we can talk about I mean, it was an explicit propaganda campaign. It sounds like you have some slides on this.
So now let me just ask you, since you said you just have a few more minutes, since herd immunity is so interesting, but we do want to make our things when we do these discussions, starting with topics, so we don't start in the middle of another one again. So can we go through the herd immunity slides? There aren't very many. Not say too much about them unless you sort of don't agree with what.
Sure, no, absolutely. I think we covered most of the basics. So let's definitely look at the issues.
But some of the real biting ones that you lived through, I do want to mention to the people. So can we do that? Okay.
Absolutely, yeah.
So here was a big problem. In 2020, the WHO changed its definition of herd immunity from herd immunity happens when a population is immune, either through vaccination or through prior exposure to the disease. Now, that is even incorrect, because when they say a population is immune, they're implying something like the whole population can't get it, and that's zero COVID, and that can't happen. Okay, so that's not a good definition. But then they changed it to herd immunity is a concept used for vaccination in which a population can be protected from a certain virus if a threshold of vaccination is reached. That is completely absurd. That it has
that's propaganda. That second one, I mean, the first one, you're right, is imprecise and misleading in some ways, but still like in the ballpark. The second one is just a lie. I mean, it's basically denies that COVID recovery provides immunity at all.
I know. Let me go on to the next slide. But
Reed, actually, can I just say one piece of irony about that second one?
Yeah.
the vaccine, and we'll talk about this later, maybe next time,
Yeah.
it itself after a few months does not protect against infection.
Right. So in a
So
way,
that means it can't ever, if it's just, if there's no natural immunity and you just have this vaccine, you would never get herd immunity anywhere like herd immunity.
you'll never get it in the simple definition that I used, you'll never get it because
Yeah.
it doesn't keep people from spreading it. And that's the whole
Yes.
principle behind herd immunity, being part of the herd when you cannot spread
Yeah.
it.
Now you would get, you would get a lot of people that are protected against severe disease.
That's right.
Yeah, but that's a different notion. So in a sense, like to deny, what they wanted to do here is deny natural immunity, deny the efficacy of immunity provided by recovery from COVID.
Right. They're just pushing that away. And I'll tell you, that is the answer to this whole thing, because that really does keep you from spreading it to someone else. Like I said before.
Until there's a variant.
Yeah, but then it's a new virus in a way. I mean, if
well, I mean, it'll still be COVID. I mean, it'll have the spike. It'll still be a variant. Yeah.
Yeah, correct. It'll be a coronavirus.
Yeah. It'll be like OC43 is recognizable, even though it mutates.
Okay.
Yeah. So it's just going to be another coronavirus. It's going to be the fifth circulating coronavirus.
Correct. Yeah.
In human populations.
Yeah. So this is the World Health Organization now, and that is absolutely absurd. You agree? Changing the
and actually they changed it in response to the Great Barrington Declaration.
Yeah, sure.
I mean, because we when we wrote about in the Great Barrington Declaration, we talked about herd immunity, because how could you not? It's not a strategy, but it's a biological fact, right? So you have to talk about it.
Exactly.
And they wanted to put the vaccine up front because, in their view, if you told people that there was such a thing as immunity after COVID recovery, it would undercut the demand for the vaccine.
Well, if they want to lie to people about it, yeah. And I'll tell you,
but that's exactly what they did.
It backfired because they got caught lying, and then everybody got scared of what they were doing.
Yeah.
But anyway, this is so ridiculous.
This was absurd. Absurd is the right word here, Reed. Right. There's literally no disagreement on this slide.
Yeah. Oh my Lord. Okay. Now, these guys said herd immunity is another word for mass murder. Now, please comment on this. Of course, they were equating focused protection of the vulnerable, a la your Great Barrington Declaration, with a let it rip strategy, which it wasn't at all. As a matter of fact, in a way, it's the opposite. Let it rip means you're going to let it spread through everybody, but you guys wanted to protect the people that were vulnerable. So it's not a let it rip, correct? Correct. Okay.
Yeah, no, I mean, that's so the thing is, there's a few notes about this, that this is so important, right? Yeah. So first of all, let it rip, it doesn't appear in the Great Barrington Declaration.
Right, sure.
In fact, I never heard or thought about the term in this way at all before, until reporters started asking me why I wanted to let the virus rip.
Yeah, it's a derogatory term, though, is my point.
It is. I agree, and it's this idea of mass murder, a word for mass murder. This is ignorance.
It is,
and it's ignorance in service of propaganda. So it's the idea was they wanted to make sure that everyone got vaccinated, and they had the wrong notion what the vaccines could do.
Right, they were wrong.
They thought the vaccines were neutralizing, permanently neutralizing.
Correct.
And this is in October of 2020, I think, when this came out, when this quote happened. This was before the vaccine trial data had been released. They had no idea what the data looked like. This was based on, sort of this hope that the vaccines would work out exactly the way they thought, and it was also based on this crazy idea that COVID recovery doesn't provide an immunity.
Right, which is totally crazy.
Which is a lie.
It's the basis for human immunology or any animal.
And then it took the popular ignorance about what the word herd immunity. Now you hear the word herd immunity. If you've never gone through the model we just went through, you hear the word herd and you think, oh, we're going to treat people like cattle.
Yeah, exactly. All of
they're exploiting this popular misconception rather than educating public what this means, which is herd immunity is actually, if you have a population that's not immune naive, that's a good thing. Instead of explaining that, they're like they're equating with mass murder. They're just feeding ignorance. This is demagoguery.
This is it's very severe problem that the United States has, Europe has it, the world has it. That's why the very last stuff we're going to finally get to talk about is about where the world is going with all this misinformation, this anti-science stuff, and these ridiculous comments made by doctors. That's what I don't understand about
this.
it.
By the way, let's do the second half of this.
Oh, you want to postpone the second half of her?
No, I want to talk about the second half of this quote. The second half of this quote.
Second half. They also said the vaccines are the only way to get to herd immunity, meaning natural immunity doesn't do anything. And once we get to 60 or 70% vaccinated, that's what they said at first, then they raised it to 90%, we would have herd immunity. That is completely wrong.
Okay, so the way this is ignorant on many levels.
Yeah, let me finish the sentence so you can comment on all of it. They completely discounted immunity in place, which would be part of it, because you're part of the herd if you have immunity in place, and natural immunity, as did all of the other experts. And I'm talking about Fauci and those guys too. They would not acknowledge it at all. But I'll tell you, I found a video of Fauci from a couple of years ago saying, oh, you would never get a vaccine if you got the disease. And I'm going to show it to you later. You won't believe it when you see it.
Okay, so let's talk about this particular statement before we talk about Fauci. The vaccines are the only way to get to herd immunity. Well, we already talked about why that's a lie. Right? In fact, the vaccine that there's natural immunity, but there's another part of that phrase that's really imprecise and sort of used in propaganda. Get to herd immunity. Well, what does that mean? What they mean is, I think, something like in a simple SIR model, have enough of the population that's in the recovered bucket such that that there's no more spread of the disease is what they're trying to imply by this.
Right.
But remember, this is a disease that the herd immunity threshold changes with seasons.
Correct.
So you can go in and out of herd immunity just based on the seasonality of the disease.
Absolutely. And also babies being born and all sorts of things. Yes.
And this is a disease that there's some immunity decline over time, especially for people who get immunocompromised or they're stressed or whatever. I think you can have that. Yeah. And so you have this get to herd immunity is like a meaningless statement here.
Yes.
So it's so imprecise. They're trying to, again, exploiting ignorance of the population. That get to herd immunity, they think, is a synonym for zero COVID. The disease is gone. Right. The epidemic is over.
Yes, that no one will get it.
Then they get to like 60 or 70% or 90%. Again, they have this like very, very simple 1 over 1 minus R0 R naught model. And that is not the right. This is a much more the transmission dynamics are much more complicated than that. There's not a single number, and you can say and we're done. And they assumed that the vaccine, once you had it, protected you forever against COVID or something like it, or it certainly stopped transmission for a very long time.
Yeah,
this is nonsense, right? They didn't know that.
Yes.
And then they equate it mass murder, meaning what? Like they thought that the only way to protect the vulnerable was by their preferred lockdown policies.
Yeah, exactly.
Which itself is mass murder.
Correct.
So I think the irony here is that these people were exploiting the ignorance of the public, accusing people who are like us, who are arguing for basic biological facts and a strategy aimed at protecting vulnerable people.
Right.
And instead arguing for a policy that in fact exposed vulnerable people.
Yes, absolutely, it did. Let me show you the next slide, because I've got the actual quotes printed in where they said it. It'll blow your mind. Look at this. This is Dr. Hazeltine, chair and president of Something Health International, is extremely concerned that the president is being advised by people who speak of herd immunity.
So he wants to basically ignore a basic biological fact.
Right, but he's extremely concerned that the president is being advised by people who speak of herd immunity.
Read it. Look at the next line. Hazelton went on to say that if the virus is allowed to spread, what exactly does it mean to allow a virus that for which we have no technology to stop the spread means by allowed to spread.
Listen, when I presented and we talked about the lockdown thing, I showed states that were in the same climate zone, like North and South Dakota, where one was very strict about masks and lockdowns and the other was not at all, right? And the graphs of the two states are so exact, it's unbelievable. Meaning the state next door that did all these crazy things versus the one that did nothing, it did not affect the virus at all, the spread. The cases versus
exactly this is so I published a study in January 2021 where we looked at the early lockdown orders in terms of stopping the spread. We looked at mandatory business closures and shelter-in-place orders, and we compared South Korea and Sweden, which didn't have those, versus lots of other European countries that did.
Mm-hmm.
And there's no correlation.
That's right.
The disease spread at equal rates in places that had those severe shelter-in-place orders and places that didn't. The lockdowns are not a technology that stops the spread of the disease, and then it's for reasons we talked about earlier. Right. It's the laptop class that can afford to stop, that can afford to abide by it. The rest of society cannot afford to abide by it unless you do some draconian thing like China does, and you lock people in their apartments forever.
Again, but it makes it worse because it turns, like you said.
Okay, no, well, let's not have that conversation again. I guess I got to run, Reed. I got to let's, because we already had that conversation before. So let's. I don't
want to get into it again because we really hashed it out. But can I read some more of these crazy quotes this guy made?
But the point is that this man, Hazeltine, in a very prominent position, is ignorant about what lockdown how it actually works and the efficacy of it. He's ignorant about what herd immunity means. And and frankly, it's like he gets these numbers like 2 million out of nowhere. Where does he get that number from? It's not from any reason. And one other thing about, like, you look at the bottom of this thing, some background. A recent study has shown that less than 10% of the U.S. population is exposed to COVID-19. That is a lie.
I know it is. Wait till you see the next slides. You won't believe how I rip these people.
You remember in April of 2020, the Santa Clara seroprevalence study, we found 3% of Santa Clara County. April in LA County was 4%. There was seroprevalence studies in New York and in Florida that were already above 6-7% in April and May.
Sure.
There is no chance that only 10% of the American population was exposed to COVID. That's based on case numbers, not on seroprevalence estimates.
But the way that they do it is, well, they do take the blood of people and check it. But again, it's because of the antibodies waning that they're missing tons of people that are totally protected, but don't have the molecules in their blood anymore. But they've had the disease, they've recovered. Wait till you see the next couple slides. I'll tell you, I rip them to pieces. How much more time do you have? Don't say 1 minute or something.
No, I can go for a little while longer. My wife's going to.
Please. This is so vitally important to you.
Okay, let's go. Keep going.
Okay, let's go. Now let me read this because it's so ridiculous. I think part of Hazeltine's problem was because he mentions Trump and everything in here. I think he just got his political ideology just took away all of his medical knowledge or something. But anyway, listen, he went on to say that if the virus is allowed to spread, as the Trump administration is allegedly,
what does it mean allowed to spread? That part is really frustrating. What technology stops the spread of the disease?
Right. That is the derogatory bent that they took towards the Great Barrington Declaration. Let it rip, allowed to spread, all these kind of phrases. You see that, right?
Yeah.
This was part of their way to besmirch yourself, Dr. Sunetra Gupta and Dr. Kuldorf, right?
Yeah.
As the authors. And again, when Collins wrote that email, it kind of all makes sense, doesn't it? They were all trying to take it down. Okay, so listen to this. It said, as the Trump administration is allegedly advocating, meaning letting the virus be allowed to spread, we are looking at 2 to 6 million Americans dead, not just this year, but every year. It's like he's completely thinking that the people that get the disease and recover could die next year or something. It just makes no sense if you think about human immunology, right? You see what I mean? How crazy it is?
It's just ignorance. It's ignorance on stilts.
Okay, now you want to go to the next slide?
Sure.
It gets thicker and deeper. This, I could have put this in the censorship part, but this is a message that Dr. Birx wrote that says, I can't be part of this with these people who believe in herd immunity and believe that we are fine with only protecting the 1.5 million Americans in long-term care facilities and not the 80 million plus with comorbidities in the populations, included the unacceptable death toll and among Native Americans, Hispanics, and Blacks. With our current mitigation scenario, we end up near 300,000 by Christmas and 500,000 by the time we have the vaccine, close to the 600,000 we lost in the 1918 flu. We have worked to find a path that is the least disruptive to the economy, but moves us under R1, and which means R equals 1, I think she means, or less than or equal to 1, and saves both the economy and American lives. All of this is dead wrong, by the way, of course. Without masks and social distancing in public and homes, we end up with twice as many deaths. She's talking about masks, reducing the deaths by a half. Weak, crazy. We are a very unhealthy nation with a lot of obesity. We will never look as good as Sweden due to our comorbidities. These are people, and they're talking about the scientists, and it may have been you. Did you go to the
It's me.
White
It's talking
House?
about me. Yeah.
Did you go to the White House near August 25th?
I did. Yeah.
She's talking about you and the other scientists. Listen to this. These are people who believe that all the curves are predetermined and mitigation is irrelevant. They are a fringe group without grounding in epidemics. She means epidemiology, I think. Public health or on the ground common sense experience. I'm happy to go out of town or whatever gives the White House cover for Wednesday. Perhaps do Annapolis and meet somebody. Fauci and I could do it together. I am open to options, but she's saying, I'm not going to even come to the meeting.
Yeah. So what happened here was that Scott Atlas, who was the president's advisor on COVID, organized a meeting between me, Martin Kulldorff, and a couple other scientists to come to the White House to talk with President Trump. Debbie Birx, who was the head of the White House task force, the medical side of this on the COVID response, you can see the response. She had no desire to meet with us. What Scott told me was that he had been presenting Birx with paper after paper explaining the problems with this kind of thinking and published papers, and she just wouldn't listen. And you can see the problems in her thinking already in this. So just to go through this line by line. First, this is before the Great Barrington Declaration.
Right.
The purpose of the White House visit wasn't to believe in herd immunity. The words herd immunity in that conversation with President Trump never came up from my mouth. I talked about the importance of school openings and the importance of protecting older populations, whether they live in long-term care facilities or not. By the way, long-term care facilities, it's not just long-term care. I mean, 40% of the deaths have been in nursing homes and other care facilities, not just long-term care facilities, like institutionalized facilities. 40% of the deaths have been in that population. So that's a very significant thing. But then 80% of the deaths from people over 65. So it's broader than just protection of these nursing homes. So she had not heard from us, but she assumed that we wanted to let it rip.
Yeah.
With just protection for 1.5 the people in long-term care facilities. She was just ignorant. She refused to listen to any of this.
Yeah.
The unacceptable death toll, the places that have the lockdown, it's those places that have had the highest death rates for Hispanics and Blacks.
Right.
It's because the lockdowns themselves have hurt those minority populations. This current mitigation scenario, she was in charge of COVID policy during this period.
A big proponent of lockdowns. I remember that.
She got her way, and they had the mitigation scenarios. We didn't end up anywhere near 300,000 or 500,000 by Christmas. That was false. She was based on bad modeling. And then she says there's going to be another double of that if you get rid of the mitigation. So she's saying there would have been 1 million dead by December of 2020. Her models were bad because they overestimated the efficacy of lockdowns. Without masks and social distancing, we ended with twice as many deaths. That's based on very bad modeling assumptions.
Right, and she only listed masks and social distancing. So the point is,
well, she also wanted to close bars and restaurants. She wanted to close schools. She wanted to close.
Proponent of the lockdowns, the biggest.
Yeah.
Really. Okay. Keep
so
going.
she got her way, and as a result, we had I think it was like 150,000 deaths by the end of December 2020. Or might have been 200,000 deaths by December 2020. And you had all of the harms of the lockdowns. The key thing is that the model was bad. It wasn't the mitigation that resulted in the 200,000. The 200,000 deaths was a failure, not a success.
Right, exactly. Right.
It's because she didn't understand the age gradient in risk. For her, this was a disease that needed to be mitigated only by lockdowns. The only way to protect anyone was to protect everyone. But in fact, by trying to mitigate the spread of the disease, she ended up infecting people.
Right. She made it worse.
That actually died as a result of it because she didn't understand who actually was at risk. Now she's talking about we'll never look as good as Sweden due to our comorbidities. Sweden looks good despite there was no mitigation. The point about Sweden was not looking as good as Sweden. The point about Sweden was they didn't do the mitigation.
Right.
And yet they look almost exactly like their neighbors.
Yeah. In other words,
better than the rest of Europe.
Did not do anything except the collateral damage caused an enormous amount of death. But the mitigations like lockdowns and masks, they just don't do anything positive.
Right. So, and when she says we believe all curves are predetermined, it's true. The virus spreads. We don't have a technology to stop the spread of the virus.
Right.
The technology we had was to protect the vulnerable.
Right.
The technology we had, and what we needed to protect the vulnerable was an all hands on deck, all of public health wide people thinking, what are the living circumstances of the vulnerable? How can we reduce the risk to them? Long-term care facility is a good example, right? Like they under the management of people like Fauci and Birx, people like Andrew Cuomo sent COVID-infected patients back to nursing homes because to them, protection of the vulnerable wasn't the priority. What was the priority was stopping the spread of the disease, something that was actually not possible. This is an email by someone who is absolutely convinced of her righteousness, is absolutely convinced that she is right in terms and a huge amount of hubris in terms of the mitigation strategies she actually suggested. And the only thing that I'd say about this that makes me sad is that President Trump actually listened to her.
Right.
The schools closed on her advice in all of 2020, like in the fall of 2020 and all of 2021, in most blue states and in many red states, as a consequence of her advice. We have 1 million dead as a consequence of Fauci's plan. An utterly failed plan. And we also still have the enormous overhang of harms from lockdowns still to pay. This is going to go down in history as an example of how misleaded that our leaders who set this strategy were in terms of their thinking. This is the email of a failure.
Absolutely. The statements in here are wrong. The data proves it so crystal clear about the shape of the curves in the places that did lockdowns and masks and the places that didn't. That's why Sweden is so important. And then she says, I can't be part of this in the first with these people who believe blah, blah, blah. In other words, she's never spoken to us. She's not willing to discuss it either. That is very, very troubling.
And look at the term believe in herd immunity. It's not a question of belief. Right. It's a question of she doesn't understand what herd immunity is. There isn't herd immunity in COVID in HIV. She's an HIV expert. She doesn't understand herd immunity. And for her, believe, it's not a question of belief. It's a question of, this is just a basic mathematical fact that pops out of these models. It's a basic biological fact of, if you have a lot of people that are COVID recovered or vaccinated, you actually have some protection just by dint of that fact.
That's why I said it's an abstract concept. It's about protecting an individual because of the status of the other people around you. So
yeah,
she doesn't seem to get that, though. They think it's a derogatory term. That's
yeah,
why they call it mass murder.
This is the thing that's sad about this is that this is an email from somebody who is in charge of our COVID response, put there by the President of the United States.
Right.
And this is a display of hubris and ignorance.
Yeah, it's just, she got everything wrong, though. I mean, she just doesn't understand this stuff at all. And she didn't interpret any of the data.
Yeah.
And that's why Scott Atlas is probably mad. I heard that he would go there with reams of studies to prove points, and they'd go in there.
He and I were talking.
And say, no, we're going to do it this way or something.
He and I were talking almost every day, and it was, it's kind of an exciting time. I mean, you lived through this too, and you probably had the same exact experience. Every day, I'm reading new papers, learning something new. Was a really exciting thing, actually, to learn about. I mean, of course, this is a deadly disease, but at the same time, it's in science and medicine. It's always fun to learn new things. That's part of the excitement of this. Certainly. She closed her mind to that. She decided from the early days of the pandemic exactly the right thing to do, and she was going to stick with it even as it failed miserably.
Right. She was just wrong, and the price people paid was just enormous.
Yeah,
wrong.
Catastrophic. The single worst mistake in public health history.
No question about it. Now, this is something from Stanford. So if you know these people, I apologize. But look at what they said in a study at the Stanford School of Medicine. They said about 9% of the people nationwide have been infected with the coronavirus, according to a new study led by Stanford investigators. This is the largest study to date to confirm that we are nowhere near herd immunity. This is on September 28th of 2020, said Julie Parsonette, MD, professor of medicine. Now, let's look at all the mistakes in this. This thing is wrong on many, many levels. Referring to the point at which a large part of the population becomes immune to a specific disease, scientists estimate that 60 to 70% of the population must have antibodies to the coronavirus before COVID-19, the disease the virus causes, fades, said Dr. Parsonette. And here's the problem with it. Number one, it's wrong to equate the number of people with antibodies to the number infected, because antibodies wane and they will not be measured in some of the people that are protected. That's number one. Number two, they are neglecting those with immunity in place. Right there, they're neglecting them because they don't have antibodies anymore in their blood, right? They just have a clonal memory. Number three, they're not even talking about T cell memory here. They're only talking about counting antibodies in people's blood. They neglected T cells. It is totally wrong to say that at that point, we were nowhere near herd immunity based on this study. We were very close at that point to herd immunity for the wild type. And I can explain all that and prove it in just a second. And of course, it's totally wrong to say that 60 to 70% of the population must have antibodies to the virus before COVID-19 fades. That is totally wrong. Again, for the reasons I listed. Clonal memory is good enough. You don't have to have the actual molecules in your blood anymore. Nobody has the molecules, the antibodies from when they got the measles vaccine, do they? No, they're all gone. It's all they have is clonal memory to the measles. Okay, now, if you let me prove this. Now, by the way, 9% of the nationwide population is 31.5 million, but I'm going to tell you why it was way higher than that at that point. This is a thing that I put in here. Fauci said 90% of the people in the US are still susceptible. And he based that comment on there being 9% or 10% of the people with antibodies that the study showed, right? That we just looked at. But that's totally wrong. because there's a lot of people that don't have antibodies that aren't susceptible. There's immunity in place people. You know, a third of the country is 100 million people. There is.
So if I'm remembering the study right, the study that Parsonet does, she is a colleague. Actually, she's acted in well, we can leave that aside.
Okay.
This study was of kidney transplant patients, dialysis patients. It wasn't representative of the population at large. The second thing about this study is that it also had a 0.2% infection fatality rate. It confirmed the study results that we had previously.
Okay, that's okay.
Although she didn't make a big deal out of this. The third thing is, you're absolutely right. The fading of antibodies means that looking just for antibodies at September without accounting for the fading of antibodies is a mistake.
Yes.
Actually, there's one other thing. You know, you can alter the false positive and false negative rates of these. She used an ELISA by changing the threshold at which you call something a positive versus a negative test.
Oh, sure, yes, definitely.
You can make it more sensitive and less specific, or more sensitive and less specific and more sensitive, or whatever, by altering the threshold.
Yes.
So you have to be very, very careful about this, about comparing. So that's all technical, but you are absolutely right. The central problem, it has to do with the way they talk about herd immunity. It displays a sort of an ignorance that is absolutely shocking from someone that's a professor of epidemiology at Stanford.
Yeah, it is.
It's not a question of near herd immunity.
Problem.
Like, she is thinking about herd immunity as if it were a synonym for zero COVID. It is absolutely ignorant. And she says it's wrong to say we're nowhere near. That's actually true. That means we actually are quite far from the disease stopping, but not for the reasons that she thinks.
I know, but when you see some stuff that I tell you in just a second, I think you'll say that we weren't that far from it. But
far from what? So, like, you'll tell me is okay. The wild type has had its play. Fine.
Yeah, because on January 7th, it dropped out of the sky, and that was the end of the wild type. So I was right.
But as far as like, are we done with the disease? No. Right. I mean, for her, it's like she's thinking of this the pandemic as this. Okay, we're just you just need to get enough people with neutralizing immunity, and we're done with the disease. She just didn't understand the nature of this disease. And then finally, the 60-70%. I completely agree with you about the antibodies, but let me add an additional thing. Where does she get that 60-70% number from? Where does scientists estimate that? Where does that number come from? It's 1 over 1 minus R naught. Okay. They had some notion of what R naught was, the number of people infected when one person is infected, how many additional people does it infect when there's no one else infected in the population.
Yeah.
1 over 1 minus R naught. That number, we had no idea what it was.
Yeah, and remember that number had to be raised to 90% because they were so wrong on this, and then Biden said 98% of the people.
Well, I mean, I think this is one of these things where they just got literally everything wrong, and the hubris again around this is just shocking.
But this thing is so wrong because, you're saying that it was in a kidney study, right? The patients all had kidney problems, but look at what it says in the article. It says in a nationally representative analysis of coronavirus antibodies. Nationally representative analysis is very misleading if it was only centered on people with kidney problems. You see what I mean? Yeah. Researchers also found high rates of infection among Black and Hispanic people and in densely populated areas. Now, when I parse this out sentence for sentence, almost every sentence is wrong. And these over on the right, these reasons are why it's wrong. And you agree with me, right?
Yeah, no, it's
missing all of this stuff. And I'll tell you, let me show you that the next slide where Fauci got on TV and said 90% of the people in the US are still susceptible. Someone asked me that. And that's why I made this video. It was a question and answer. And I said, no, Dr. Fauci is wrong. Just because 10% of the people have antibodies in a sample, a proper scientific sample of the country, doesn't mean that 90% are susceptible to the disease. There were very few people still susceptible at that point, maybe 25% or something, not 90. Okay, so everybody forgot about T cell mediated immunity and many other immune defenses, by the way, like I said, like immunity in place, of which we have abundant proof of long lasting protection. Or they just wanted to keep the people frightened by saying 90% are still susceptible.
Well, I think that
perhaps to increase vaccination. You see,
yeah, I think
right
this
here.
every word of this slide is correct.
Yes.
I think
Absolutely.
they basically ignored, they wanted to undermine the idea that if you are infected and recovered, you actually have protection. Like that, you saw
Right.
that the World Health Organization thing, and any evidence that they could, that where it suggested that there were people that were protected was a threat to their strategy for some reason.
I know,
Instead
but
of just
why
like,
would this doctor, Dr.
Julie
Parsonet, why
Parsonet,
would
yeah.
she either go along with it, or does she not know all that, or what? I mean, that's what people like me couldn't understand. Why would she make all these mistakes in her analysis when a freshman medical student should know this? You know, the whole thing's mind-boggling.
I mean, I think a lot of these doctors had a lot of political motivations. This is July or December, whatever. This is
September 28th. This is almost October. This is
so I mean, it's like
Trump.
at the front of their heads is Trump, not science.
I know, but look how dangerous it is. Look what they did because of that. Look at the policies Deborah Birx pushed for. I mean, it killed a lot of people, as we know. 100 million was starved to death. All right, let's go to the next thing.
100 million thrown into poverty, tens of millions starved to death. Yeah, or had food insecurity.
Well, I've got the exact numbers about from the World Food Program, and the 265 million have acute food shortages. 100 million went into the extreme poverty category because of it, living on less than $1 a day. You know, I've got all this.
Read, it's unbelievable. It's unbelievable
what it caused. Okay, let me just show you how screwed up this is. Now, this is a guy who's not a doctor. He's a newsreader or something, a business guy. But it explains the problem. He said, I've had the disease and I have antibodies to prove it. And then he did an antibody test, his third one, that came back negative. Big deal. It doesn't mean a thing. But he was in shock, he says, right? Right? Because his first two tests said, yeah, you have enough antibodies.
October 14th, 2020. Right. The thing is October 14, 2020, there was a tremendous amount of evidence that if you had COVID and recovered, you actually had substantial protection.
Sure.
There were so few reinfections documented to that date. That by itself was enough.
Human immunology would have told you you're protected.
And actually, there were like all these papers. I mean, this is why we wrote the Great Barrington Declaration in part. Like there were all these papers published in places like Cell and Nature that documented the T cell immunity you're talking about, that documented the B cell immunity you're talking about, that documented that some of the mechanisms by which COVID recovery provides protection against against reinfection and severe disease on reinfection.
Correct.
So I mean, this is like just ignorance.
Yeah, absolutely. But listen now for a second, because you wouldn't expect this guy to know anything, and he doesn't. But that's okay. But I'm going to show you the next slide, which really is disturbing. But I don't read papers very often. I like to figure it out from the basic science. And if you just look at the way the human immune system works, of course, people are protected after they've had the disease. They've got clonal expansion of B and T cells. And T cells are more important than a viral infection because when the major histocompatibility complex presents the antigen, the peptide, in the context of the class 1 MHC, then the T killer cells recognize class 1 major histocompatibility complex, and then they will kill the cell. Okay? So that's a more efficient way of dealing with a viral infection where the virus enters the cell and hijacks the immune machinery, the replication machinery of the cell. So T cells are more important than antibodies in a virus.
Yeah.
They're more effective at getting rid of it. So these people are completely neglecting T cells the whole time. Let me show you the next one though. So he goes into and finds out why. his antibodies are 0. So it says, oh no, Mr. Quest does have antibodies, just not enough to register on the scale. Right. So he gets a negative test back, right?
Yeah.
Now, he starts to study this, and look at this. He says, over the past 5 months, my evanescent antibodies have dwindled to a meaningless amount, and with it, my bravado to claim protection. That is totally wrong. Your antibodies can go to 0 and you're still completely protected.
This is not a scientist, right?
Oh no, he's just a person. So he doesn't
Well,
know.
no, the thing is, I have a lot of sympathy for him. Like, what does he know? Right?
He doesn't
He's
know.
being
And
misled.
so the point, though, is that down here he talks to his doctor. Let me tell you what his doctor said. He says, when I told my infectious disease doctor, this is an infectious disease doctor like Dr. Walensky, he wasn't one bit surprised. He referred to the latest studies showing that antibodies do indeed weaken. Why would he need the latest studies? All right. But anyway, he's referred to the studies and says that. Now, listen, they dwindle over 90 days. No one has had a chance to do much research beyond that. As if he doesn't know there's clonal memory, this infectious disease doctor. See what I mean? He's saying,
Well, I mean, they're not reading the literature. Like I said,
research to know.
In October, Reed, this was 10 days after the Great Barrington Declaration. The evidence was absolutely overwhelming that there was that recovery from COVID provided all this protection against reinfection, severe disease.
Of course,
A
but you
ton
don't
of
even need
evidence.
infection. You know it from freshman year at medical school, how all this thing works. Of course,
The funny thing is, in April, when we ran the seroprevalence study, the Institutional Review Board made it very clear, and our immunology colleagues made it very clear that we shouldn't assume that there was going to be protection after COVID recovery in April of 2020.
Why shouldn't you assume it?
So that was because they hadn't been proved yet.
Yeah, but you know it from your understanding of human immunology.
But Reed, I'll tell you, I think a lot of it had to do with that a lot of these folks were thinking of HIV. With HIV,
Right.
There's no immunity.
Right.
So, well, what if this is like HIV? This is a novel disease we don't know. So don't assume that you can know. I accepted that in April of 2020 because I'm like, okay, I'm not an immunologist. I'm an epidemiologist. So I'll just accept that. But by October of 2020, that was not a tenable position anymore. A tremendous amount of immunological work had come out, and a lot of epidemiological work had come out to show that there was not that much. There's very rare reinfection, and so that you could not in October of 2020 that profession of ignorance was itself ignorant. It is not true that we didn't know that there was protection by October 2020. That's just false.
Right. Okay, very good. Let's go to the next slide because I do want to wrap this part up before we get to the next topic because I know you want to leave. Your wife's going to kill me when I finally leave. All right, let me tell you how many people had been exposed in the US by September 20th of 2020. Not 31 million like the Parsonet study showed. Okay? It was about 155 million people had already been exposed. And let me tell you how I figured it out. The WHO said with certainty that 10% of the world had been exposed to this by that date. So 10% of 7.85 billion is 785 million, okay? That's what the WHO said had been exposed to the virus at that point. Johns Hopkins, who had undercounted the whole year, was saying that 45.7 million had been exposed worldwide. Johns Hopkins said that when the WHO is saying 785 million. The ratio of those two to determine the undercounting factor of Johns Hopkins is 17.2, meaning Johns Hopkins was undercounting the people that had been exposed in the world by a factor of 17.2. All of that is factual. I got it right off. I got the 45.7 million number as of that day, okay? Now, Johns Hopkins also said that about 9 million people in the US have been exposed so far, which is way too low on September 20th of 2020. And I'll tell you, it makes sense to multiply their undercounting factor by 9 million to get the true amount that had been exposed in America. And that's how I came up with 155 million. You see how I did it?
Yeah, I mean, so
In other words, at that point, less than half, but around 40% or so of the United States had already been exposed to this. Remember those
okay, so
huge waves in Europe and America and everywhere else. Now, that is really important because when you add immunity in place to this, then you're talking about being immunity in place adds another 120 million or so. Let's say 100 million, 120. That gets you at about 270 million. And we only have 360 million in the whole country. So at this point, 270 million people had already been exposed or were protected before from this, okay? And that's why that's why the graph went to the floor in January. Let me show it to you.
okay, so let me so one way to do this, one way to back up and check this, Reed, is by backing up. So let's say we accept something like and I know that you think this is high. I also probably think this is high, but let's say 0.4% infection fatality rate. Okay.
Okay.
So if it's 0.4%,
Yeah.
times 155 million. Let's just run the numbers on that.
Yeah.
155 million times 0.4%. That should have produced 620,000 deaths.
Okay, hang on. Well, I think that's too
I
high
think
by that
that's
amount. Because at this point, there were 169,000 deaths.
Yeah. So I think that means that means if we have a 0.4% infection fatality rate, this is off by a factor of about 2 or 3.
But we don't have a 0.4% infection fatality rate for a lot of reasons.
Right. So let's say it's a 0.2%.
Well, then you'd have it.
Yeah. So
300,000 deaths, which is not even double what there were. So I've got it within a factor of doubling.
So this is consistent with a 0.1% infection fatality rate.
Right, which fits my reasoning from the beginning. Remember, I did it on the cruise ship and got 0.1%.
Okay, so I mean, let me just say, I don't know the right number, but I'll tell you this: it's definitely not 10%, which is 35 million. That basically is a ridiculous number.
Well, Stanford had it at 31.9 million or whatever I just read you.
Yeah, actually, their study was in July, so I'm a little confused by the September study. I'm not sure what that means.
You mean why the article was on September 28th?
Yeah, because the article that I know of from Parsons.
I'll tell you, those kind of articles normally come out very quickly when they're done, because this is big news.
No, I'm pretty sure like she did the study in July with the dialysis centers. That was definitely a July article.
Okay, maybe she did something else September, because there's a big.
It's possible, yeah. I don't know.
But whatever it is, it's all wrong, and for these reasons. And I think these stories usually do come out close to when they're printed, because this is good news to the set that wants to scare people and wants to push the vaccine and everything. The liberal press does not wait to put stories out like this. Okay.
Yeah, I mean, this
is the topic. Fewer than 1 in 10 Americans have antibodies to coronavirus, study finds. That is there to scare people. But let me move on now, because this is going to mean a lot of things in just a second. I think this number is extremely accurate, because look, it goes by what the WHO says, and they're monitoring the number of people exposed in all kinds of countries that we don't even know about. And Johns Hopkins was really low the whole time. I mean, they're 17.2 times too low. Okay. And then when you multiply what they said had been exposed in the US, you get this number. And when you put in the infection fatality rate of 0.12, I bet it comes out real close to exactly this number. I haven't checked it yet. That was a good, smart thing that you did. But put in 0.12 for a second and see what you get. Will you just check it real fast? You got 600 when you put in 0.4.
Yeah. So so it was 155 million.
Yep. Times 0.12%. So it'd be.
Okay. So.
0.0012
Okay, so 155
million. Yeah,
times 0.12%.
yeah, which is 0.0012.
186,000.
Bang. See how close I am? It's incredible. It all makes sense when you think it through and do the math. Now, this thing we don't even need to discuss. Sorry, zero COVID is not possible. That's just what I said on that slide. And it shows that all these countries who did think it was possible got the hell knocked out of them recently. You see?
Yeah, well, there's no technology to get zero COVID.
You can't get
There's
it.
animal vectors.
The reason these places looked real good for a long time is it does help to be an island out in the middle of the ocean. Let's face it. Okay. And we're talking about where? New Zealand, Australia, and South Korea, which is almost an island because its northern border is North Korea, and nobody crosses that border. It might as well be an ocean. You know what I mean?
Yeah.
Okay, let's go to the next one quickly. Okay, the cases absolutely fell off a cliff on January 11th, 2021. Remember that? This is January 11th right here, 756. Okay, right here is the peak of the wild type. Now, my point was this happened because I was against these people saying you needed to vaccinate everyone to get this. The cases peaked on January 11th with not a single person vaccinated in the United States. Think about that for a second, because the vaccines got released on December 14th. Right here, vaccines got released on December 14th. Remember that?
Yeah.
So the first thing you have to do is add 3 weeks to it to get an immune response.
Yeah.
And then you're on January 7th by then. That's 4 days short of January 11th. You see? So nobody was fully vaccinated. Not a single person in the United States was fully vaccinated on the day that the cases dropped to zero. Went straight down. Okay?
Yeah, no, this is COVID seasonality.
No, it's not though, because let me respectfully ask you if it is or isn't, instead of saying, no, it's not. Sorry about that.
That's okay. We can disagree
January
a little bit.
11th is way too early for the season to be over. So on the next slide.
No,
now,
if you're gonna say it's herd immunity, I'll agree with you.
Well, hang on
but
for a
it's not.
second.
Those are not inconsistent, right?
No, not at all. Let me just finish this real quick. This is the graph of vaccinations administered per 100,000 people with time. And as you can see, since we started on December 14th, it's zero over here. You got to add 3 weeks. You get to right here. Then there's like just a couple days before the January 11th, right?
Yeah.
From one dose, though, just one dose. Okay,
Yeah.
so nobody was fully vaccinated, and yet we reached herd immunity. Let me tell you why. Why did it drop so precipitously? Was the seasonal bump over? You know, the seasonal part? No, it wasn't. January 11th is way too early for the seasonal part to be over. It's freezing cold everywhere in February up north.
Yeah.
Did it get unseasonably warm and sunny? Like, was there some kind of really weird weather thing that year that caused it to fall off the map? No, this was the year, if you'll remember, that Texas, it was so cold in Texas, they almost lost their entire electric grid because of it. Remember that?
Yeah.
This was one of the coldest winters in memory. It absolutely almost devastated Texas and destroyed their electric grid. Remember that? People were freezing to death and everything. Number 3, did they change the cycle threshold on the PCR test to make the cases drop? No, they didn't until later. Remember, that was something Biden wanted to do to make him look good, maybe, or something. I don't know.
Yeah.
But it was not before January 11th. They talked about it, but they didn't do it until later. So that's not the reason the cases dropped. Okay? You with me? Did mask wearing, lockdowns, and social distancing finally have an effect? Come on, no chance, right? Oh, it was the vaccines. No, the vaccines had absolutely nothing to do with the drops in cases, hospitalizations, and deaths. Had nothing to do with it. You know what the answer
Okay, so
is?
so let me just say I think I agree with almost everything on this slide.
Okay.
The only part I push back a tiny bit is the first one. I don't know exactly the dates of the seasonal bump because we don't fully know the parameters of the seasonality. Like for instance, like there's some discussion about humidity playing a role. I mean, there's a whole bunch of things that might go into it. So is the seasonal bump over? So the pushback would be this. We don't need, it doesn't have to be completely over. It just has to be that it could be on that the herd immunity threshold is declining because of seasonality. And so you get both what you're saying, which is that you're getting a large fraction of the population, immune,
Yeah.
and also seasonality
Yeah.
together.
Oh,
They act together, right?
Okay. I understand what you're saying 100%. And I'm not an expert in whatever you have to be to know when the season actually starts or ends. But I'll tell you, on January, I went to college in Boston, Cambridge, Massachusetts. I was a resident in Cleveland. And I'll tell you, it doesn't warm. We had a tennis match snowed out in May.
No, so the thing is like the question is like, how does COVID respond to the weather?
Is it season? Yeah.
Yeah. So I don't know. I don't think we fully know.
This was the first season. We really don't know. You're right.
Yeah. So I think the thing is I think they work together. Remember, we were talking about the herd immunity thresholds can vary with the season.
Oh, sure. Yeah.
And so if you have, look, imagine the herd immunity threshold is declining while the fraction infected is going up. You get the crossing of the fraction of the population that's immune, COVID recovered or whatever, while the herd immunity threshold is going down. Both together are acting to have the case curve come down.
Okay, so can I just throw one little question in there? It dropped down so fast, and certainly if the season is sort of changing on January 11th, which I think is way too early, because the reason you have a season still exists on January 11th. It's real cold. People are in close contact. Their vitamin D levels are low. All those things are still there on January 11th. So I'd be shocked if someone told me the season ended in December or something.
Well, so the question is, it's not a 1-0, right? It's the way to think about it is the herd immunity threshold goes up, and then at the peak season, it's the highest, and then it starts going down, right? So that's the herd immunity threshold. The fraction immune goes up and up and up as people get infected. The case curve then is going to sharply go down as soon as the herd immunity, the fraction recovered drops below the herd immunity threshold.
Correct.
Now, that can result in a very sharp drop in the case curve.
Yeah.
Right. Essentially, because now by that standard, then whenever the case curve goes down, you have a local situation where the percent protected is above the herd immunity threshold.
Yes.
Whenever it goes down, that's just by definition.
Yeah, by definition. Because again, going back to my simple way of defining herd immunity, which I did on that one page, remember? And then you told me there are many nuances to it, which I didn't really know. But in the simple way of looking at it, what happens when the peak is like this is, the virus is struggling mightily to find anyone else to infect because everybody's protected around it. And it just can't find anybody. So that R number doesn't just drop to 0.9, it drops to 0.1 or something.
Yeah, it goes negative.
The virus can't find anyone else to infect to make the cases go up. So it just goes boom. You see what I mean?
Yeah.
There you have it. And
I mean, but you're right. Whenever it's that coming down, by definition, you're above the herd immunity threshold.
Sure. That's what I'm saying about all this, and the 155 million and the people that had immunity in place knocked it up to 270 in September. So imagine how many more people all this time got exposed to it. This huge peak here caused way more than 155 million to be exposed by January 11th.
Yeah.
And by that time, I'm not kidding, maybe 220 where it had been exposed, 220 million. Then when you add the 120 to the 100 million of immunity in place, you've almost got the whole population of the United States, and that's why it dropped.
what you want, like what you really want, if you want that number, like one way to do it is you have to be careful about who's exposed, right? So you look at the death rates by age, you get the total number of deaths by age, and you have the infection fatality rate by age. For each age group, you calculate the number exposed based on the deaths divided by the infection fatality rate for that age. So in a country, for instance, that did good focus protection, you'll get fewer deaths in the old. And so
Yeah,
because you expose them less.
Focus protection, yeah.
Whereas a country that did poor focus protection, you get sort of more equal exposure. And so you have to, like, if you want, like a pretty general method of doing this is by looking at the death rates and using what you know about the infection fatality rate from these seroprevalence studies to calculate. I haven't seen anyone do a very careful analysis of this, but this, I mean, Reed, I think you're not, you're totally in the ballpark. I mean, I can't say for certain it's right, but it's not. But in terms of like plausibility, you're absolutely right. Look at the sharp decline in the number of cases.
And it happens abruptly when it happens too. Think about it. The virus, all of a sudden, the person's walking around that's infectious, right?
Yeah.
So he goes to his business. Everybody's protected there. The virus can't jump to another person. Then he goes to his tennis club and he starts to feel a little sick, but he talks to the tennis pro and 10 people that are playing tennis there. They're all protected. Then he goes home. His wife is protected. His kids are protected. And he recovers and never even gave it to one person.
Yeah.
Because so many people by that time are protected. They've all been exposed, according to my calculations. And that's why the thing literally drops out of the ceiling, because a lot of people are walking around. The people that are still sick can't find anybody that's not been exposed yet.
Yeah.
See what I mean? Because so many people have been exposed or have immunity in place. The vaccine had absolutely nothing to do with it. Do you agree with my logic?
I completely agree with that.
Nobody had antibodies from the vaccine yet.
Now, I mean, you have to, I wouldn't say zero exactly, because there were some people that were in the clinical trial. There were,
okay.
And there's some people got it like
people. Negligible, absolutely negligible. You know? So anyway, there it is. I think that's what happened there. And it never came back. The wild type never responded from there.
Yeah, right after that, you got the alpha variant.
Now, alpha was a weak variant, and then delta hit in the summer, and delta was a very strong contagious variant. But I'll tell you, we hit herd immunity on delta quicker because it was more contagious, and it's gone by December, right, of the next year. And then Omicron just took an enormous peak because it was so contagious, right?
Yeah.
And obviously, having had the wild type did not protect you from getting Omicron.
Yeah.
And neither did the vaccine. So many people that had the vaccine got Omicron. The numbers are unbelievable, right?
Yeah. No, I think well, let's talk about the vaccine and what it does and doesn't do
in part 4. Yeah. Okay. Now, so this is my logic on all this. So it was a matter of people that had been exposed was way higher than everyone said based on the antibodies. What a crazy way to guess that. But my way of doing it was a good way. So I got a much closer number, right?
Yeah, I think
31.5 million. I got 155 million in September. So it was probably 220. And
although I guess one thing in the spirit of your method, Reed, is maybe start with the US specific case numbers, because you went from the world case numbers to the US case numbers, right? If I understood your method correctly.
Right.
Could you just start directly with the US case numbers?
Well, Johns Hopkins got the monopoly on that, and they've been too low the whole time on cases. Remember, because they were only counting confirmed cases. They weren't counting asymptomatic people.
Yeah.
That's why they were so wrong the whole time, Did you remember how bad Johns Hopkins numbers were? They were so far off.
Yeah, I think like this one, I think is a Financial Times graph, if I'm looking at this right. Yeah.
This graph
source
here?
Hopkins.
No,
I see this Financial Times graph from Hopkins as a source.
No, this is Our World in Data,
but Hopkins is a source.
Yeah.
They use Hopkins. I mean, I think the thing is the case numbers. I mean, it's just hard to interpret the case numbers, right? It depends on testing. It depends on a million things, right?
I
The
know
key
that's
thing-
why I went by the WHO doing a very scientific, I hope, survey of the whole world and saying 10% of the people have been exposed.
that was so I think that we're using there. That's based on there must be sero surveys. There's no other way to get that number.
Well, if you do it intelligently, that'll work fine because we know that it takes about 90 days for the antibodies to be gone. Right? So if someone had COVID in March and you do the survey in July, you don't expect them to have antibodies anymore.
Yeah.
I'm telling you, this is really accurate and it fits what happened exactly, almost exactly. I mean, this is when you would expect, based on my numbers, that we would reach herd immunity and the bottom would fall out of it. And that's what happened.
Yeah, it's interesting. I mean, it's interesting how close it comes, isn't it?
It's right on the money. I mean, back in September, when Julie Parsonette said, we're nowhere near herd immunity, thinking that only 10% of the people were protected, she was wrong. It was 200, it was about 250 million people were protected at that point. That's not enough for herd immunity. But when you went through, this is September right here, right? When you go through October and November, that last group of about 60 million or 70 million people, when you multiply this all out, it'll be the area under this curve and it'll be real close to the number based on my number until you get to whatever the herd immunity number is. And it's high. It might be, it's not 60%, that's for sure. I had that in September. It's about 90%. And I hit it right on the money. Bam.
Yeah, I mean, I think it's like I guess I was thinking about it differently in terms of like how to calculate it. But I think you have like it's nice in science when you have convergent answers from different like with different calculations.
Yeah,
I completely agree. Like the Parsonette estimate that's 30 million. That's just nonsense.
That's no good.
It has to be. It had to have been a multiple, like a much greater multiple of that. And I think it's. You know, I guess I'm not sure it's 0.1. I mean, 0.1% sounds low to me.
Well, let me tell you why it's not though. When I did the cruise ship, remember we went over that in part one?
Yeah. I mean, I guess you're right. So the question is like whether that kind of estimate's right or the seroprevalence estimates of 0.2 is right.
Well, I'll tell you, I certainly wouldn't say that the guys that know a lot more about this than me were wrong and I was right.
Well, it's not a question of right or wrong. It's a question of how do you interpret the evidence in front of you. Like, you might be right, Lee.
But
it's a question of like what if the death because the seroprevalence numbers from the early days gets the denominator right. But you're saying the numerator.
When did y'all do those seroprevalence studies?
April 2020.
January, February, March, then you start losing the people who don't have antibodies anymore that have been exposed.
Yeah, but you know, I think like it really the thing took off.
Huh?
Like if you look at the cases, March, it's really late after March. Like take a look at this number here. Take a look at your graph right here, right?
Yeah.
It's really March and April where you start to see the big uptick.
Yeah, right here. That's correct. Now,
yeah, so we hadn't had a lot of antibody fading by then. When we did it.
Didn't, but you had enough to change the seroprevalence just a little bit so that we don't have the same answer.
Yeah, I mean, I think it's interesting. I mean, I think we're all in the ballpark. Obviously, very close in the same ballpark. Because the principle, I completely agree with you. It must have been a lot higher. And you're absolutely and your point about the decline in cases. That's herd immunity. That means that you're above the herd immunity threshold.
Absolutely, that's the only explanation for it.
I mean, that's by definition, Reed.
By definition, yeah. There's no other explanation for it of the reason why it happened.
Well, I mean, the herd immunity threshold can vary, so there's reasoning behind that. But the fact that cases are declining is evidence that you're above the herd immunity threshold.
Yeah. Again, just think of the way that someone like me who doesn't know any epidemiology, I never studied anything like that. But I think to myself, how is that virus going to go from one person to another when you've got this huge fraction that have already been exposed to it and are protected?
Yeah. I'll tell you what, though. I
So the
think,
cases are going to drop straight down when that happens.
yeah, I think, like, I think you're like, I'm pretty sure Senator Gupta would agree with you. So you're in good company.
Oh, good. I hope she'll send her this video and see what she says. She might find it very interesting that I went about it a completely different way. You know, in one of my essays in something, because I wrote that what you said is very true. When you solve a problem with two completely different ways and get the same answer, you can rule out a careless mistake. So when I took the SAT math or something, I would do all the problems whatever way I wanted to, and then I'd go back and do them all a different way. And if I got a different answer, I had to check the first way to see that I didn't add 7 and 9 and get 14 or something. You see what I mean? So, but when I got the same answer on every question, I knew I'd gotten them all right.
Yeah.
Because I did them completely different ways.
Yeah.
See what I mean? So, you know, you guys did have to worry about slightly the issue of the antibodies fading faster in some people. You know, people metabolize things at different rates too. You know, they're going to have different ways of getting rid of their antibodies differently. But when I did the cruise ship, I didn't have to worry about that at all. You see, because everybody got sick within the month that I did all of my calculations. You see,
Yeah.
See what I mean? That's why you can end up just a little high because you didn't take into consideration some people that had been exposed that didn't have antibodies.
Yeah.
What about the people with immunity in place? They're part of my calculation, but they're not really part of yours if you just did it by what fraction of the population has antibodies. You see, you could easily double or triple my number. And if you want to go up to 0.4, then you've quadrupled it. And it's because you might have missed some of the people that were protected.
Yeah, it's I mean, I think it's an interesting approach. I mean, just basically extrapolating from the World Health Organization 10%.
Yeah, and being suspicious about it. I knew when I read that article that 31 million people had been exposed out of 360 million people in the country was so far off. It was incredible. It was 5 times off. It was 20% of the number.
Yeah. No, I remember Fauci going around talking about it.
Yeah, all these TV guys kept saying, 90% of the people are vulnerable. I'm thinking, are you kidding me? Come on.
Well, I mean, I think your idea about their motivation was right. They didn't want people. They thought the vaccine was coming, and they wanted to make sure that everyone got the vaccine.
Exactly, absolutely. All this thing, the willingness to let the cases go real high when they weren't that high by using a crummy test like the PCR was part of it too.
Yeah, I think.
Yeah, and they called them new cases. That's what really bothered me about it, because I knew that a test where you're swabbing people's nasopharynx is going to have pieces of the RNA in it, and that's what the PCR test does. You know, it amplifies the the nucleotide string that you get in there until it's big enough to perform chemical tests on, like, is it there or not? So they're running this thing up to 1 trillion times and then saying it's a new case. You see what I mean? On CNN every day, the new cases today are so high. Nonsense. All of it was nonsense. It was.
I don't disagree with any of that.
Yeah, let me finish herd immunity before your wife sends me some anthrax in the mail or something. So the government doctors, all of these people, Fauci, Blix, Collins, Redfield, Walensky, even the TV doctors, Sanjay Gupta, Alina Wen, Reiner, Rainey, Hazeltine, all of them, everyone that came on CNN were 100% wrong about the infection fatality rate. That everything I've done up to this point proves that, right?
Yeah.
They were saying it was 4%. They were wrong about masks, lockdowns, waves. They were calling things third waves when all it was the first wave in a different part of the country because it was in a different climate zone. Remember that? They were saying it's a third wave now. Oh my God. It was the first wave everywhere.
Yeah.
Again, because of the understanding of what happens when you reach the herd immunity threshold.
Yeah. No, they didn't. They just
You,
they
you don't
knew
have
they.
people left to infect. It couldn't be the third wave. Come on. All right.
It's just
So,
depressing reading this because it's all true. I mean,
yeah,
I think like
absolutely true. And here's what frustrated me about this during the year. I understood this so well from the beginning. And I wrote the letters to the TV hosts to tell them the United States is getting ready to make extremely damaging, destructive policies because they have the infection fatality rate 40 times too high at 4%. That was the average of all those places. And nobody wrote me back. I feel like I could have averted the whole problem, hundreds of millions of people dying, if they listened to me and let me prove it to them. But they didn't write me back. I even wrote the White House. I kind of didn't expect to hear back from them, but that was another place I wrote. Please let me talk to
Reed,
someone.
can I tell you a depressing thing? I've talked to the White House in August of 2020.
Yeah,
I wrote the Great Barrington Declaration
yeah,
in October 2020, and
right.
we lost the public policy fight to Fauci, Birx, Collins, Redfield, Walensky, and Gupta.
But in my opinion, they cheated because they wouldn't even show up to the meeting to hash it out scientifically with you. That is why they won the argument, not because you didn't have the proper reasoning behind you.
I completely agree. They were so confident they were right that they dismissed any contrary argument as if we're just murderers.
Yeah, it was just
but in fact, they themselves were ignorant about every single aspect of the policy, about the science and of the disease, and they used their position, their political position, to get their way. And that's
they
it.
kind of bullied you and avoided you when you wanted to sit down and hash it out with numbers and graphs and everything. They just rejected it. Let me finish with this. They were also wrong about school closures. Boy, that's a biggie. They were wrong about the need to have 90% of the population vaccinated to reach herd immunity. We reached it without even one person, not 1%, one person being fully vaccinated. Isn't that amazing?
Yeah.
All were wrong. All of these people were wrong on almost every call when you think about it. Certainly every major call, they did the wrong thing. They did lockdowns. That's a major thing.
Think about school closures. That school closures by itself, there was an estimate in pediatrics, JAMA Pediatrics, in that fall that because when you close schools even for a short time, children have that has ripple consequences in the lives of children. They lead shorter, poorer, less healthy lives. Yes. And there's a long literature going back a decade or more that establishes this, the importance of children staying in school. So just the spring school closure alone, the estimate said that we cost American children 5.5 million life years.
It's scary.
And for what? It didn't control the spread of the disease. It didn't protect older people. It was for nothing. It was just based on their hubris. These people like Fauci, Birx, Collins, Walensky.
Right. And that's the right word, because it's all they had to do was look at the graphs. All these things they had put in place.
Well,
did not affect the graphs.
You and I have had this nice conversation, and we've had places where we agree and places where we disagree, and mostly we agree. But and I've learned from you, and I hope you learned some stuff from me.
Sure.
This is how science is supposed to work. You're supposed to be open-minded, so that if I'm not coming into this conversation thinking I'm not going to learn anything. Why would I do that? That would be dumb on my part. I've learned stuff from you. Why did they close their minds?
I don't understand it. I mean, it was, I guess it was part ego. It was part political ideology. Maybe it was.
It's hubris.
Job
It's like a Shakespearean tragedy.
It was because it really, part of it came down to money. I mean, part of this is about money. Why was I and you, we came at it completely differently. And I applaud you for being able to make your ideas, to be able to get them out to the public. I had all these ideas. I'd done these calculations. I knew everything was way off. And is all I could do was make videos and posts on Facebook. Facebook took down my post, the first one I did when I proved that the virus came from a lab in February of 2020. They took it down. I've made 200 more posts saying all of this along the way during the year. Me making these slides is for the people watching this presentation, for their benefit. I don't need to look at any of this. I can say it all without looking at the slide.
Reed, you know, I mean, you must have been so frustrated.
I'm
I'll tell
still
you,
frustrated. Why can't Joe Rogan have me on when he has all these people on that say 2 + 2 = 5 all the time?
I'll tell you what, Reed, I was frustrated too, and you know, and that's despite being able to be. Like, I was on a podcast. I was on a podcast. This was a roundtable, policy roundtable with Governor DeSantis in March of 2021.
Yeah.
And
Okay.
I said, which is true, that there was no randomized study that shows that masking children stops disease spread.
Yeah.
That's just a fact.
Fact. I said
YouTube-
there's no justification for putting masks on children.
On children. So
Totally same statement. But of course,
I said this. But
it's
this is a roundtable read with the governor of Florida.
Yeah.
He's talking to his constituents, showing him what scientific advisors are telling him.
Right.
YouTube censored the video of the governor of Florida.
Isn't that insane? And here's the other thing. And this is with people exchanging ideas. Of course, a few suggestions or speculations might be wrong, but that doesn't mean you're spreading misinformation.
No, it's
It
just,
means that-
it's so deeply offensive. I mean, even like it basically, it's a violation of what science should be about. But it's also Reed, yeah, like we have this tradition of free speech in the United States.
Right. But
We have this tradition of transparency in government. Like, so a sitting governor shows the public what his scientific advisors are telling him, or some scientific advisors are telling him. And somehow the big tech, by the way, I think that they were working on the behest of people like Fauci, suppress that.
Oh, yes. Yeah. Wait till you see the evidence I have about that. You're not going to believe it. And here's the problem, which you're getting at. Not only does everyone have free speech, and I do believe that doctors have a responsibility to not say something blatantly wrong to the public when they know this person's a doctor, like it's a good idea to do something that we all know is wrong. I think the doctor's wrong there. But our stuff is based on reasoning. It was Fauci and Blix that were saying the incorrect things, not me. Everything I said was right. And that's what I tell people. I say, please find one mistake in any of my videos and show it to me. You know, and here's the thing. YouTube took my videos down. Just like you're talking about, they took the one with you and DeSantis and the panel down, right? They took my videos down, and the ones they took down, if I read you, if you listened to them, you'd say there wasn't a single word wrong in there. As a matter of fact, it was brilliant or something. I mean, you'd say, "Oh wow, that's very good insight as to what's going on here." Just like I would if I listened. I learned from something from it. Like they took them, but they took them down. I mean, it wasn't even close to being incorrect or misinformation. It's like let me tell you, they took a video down of mine where I told them that Fauci was wrong because he said 90% of the people are still vulnerable. I'm right. Fauci's wrong.
That's correct.
You know what I'm saying? You saw the slide. I showed it to you. They're taking videos like that down because I mentioned Fauci in a kind of a negative way, saying he's wrong. But let's be honest with the people. This whole business of masks, Fauci, as you know, said masks. We've been through this already, but you know, he said the opposite 2 times and was allowed to do it. So that shows you right there that they weren't taking things down because some of it was wrong. Let me keep going. Let's finish up herd immunity real fast.
Okay.
This just makes my blood boil. This is on January 10th of 2021. So this is right the day before herd immunity got reached. I wrote this thing about variants. People ask me, what do all these variants mean? We had alpha, we had delta, or whatever. No, we hadn't had those yet. But there were mentions of it, of what was going to happen, because I had said in my videos, I'll tell you, I was lucky on a lot of things. I said that in RNA viruses, there are more mutations. That's a basic science thing, okay? And spike proteins mutate more than the non-structural proteins, the N proteins and the M proteins. You remember that slide where I said we found 23 people that had SARS-CoV-1 that were still alive, and they had antibodies and T cell memory, not antibodies, I'm sorry. They had clonal memory of T cells to the N protein, which was actually the same exact N protein that's in SARS-2. Because I was making the point that when all these people were saying that, oh, we don't know how long natural immunity is going to last, it may only last a couple months. And I said, come on, in SARS-1, it lasted 17 years. Okay, okay. So I'd made videos about that. And about what would happen when we got variants. I said, this is right when everybody's all been out of shape and uptight about the vaccines. So I wrote things about what variants were and that you might need to take another shot. I said, they'll call it a booster, but it'll really be another shot. I just called it exactly like it was. But anyway, listen to this. Variants of COVID are due to mutations in the gene sequences coding for the spike proteins. This highlights the reason why exposure to the actual virus confers better protection than getting the vaccine, which begs the question, why are the experts demanding and possibly mandating that people who have been exposed or have immunity in place get the vaccine? Remember, they kept saying that. They said, even if you've had the disease, you got to get the vaccine anyway. So I'm saying that doesn't make any sense there, right? I'm saying they're mandating that people who have already had the disease have to get the vaccine. Okay, listen, the vaccine only makes antibodies and creates memory B and T lines to spike proteins, while exposure to the virus gives rise to lines for N, M, non-structural proteins, and 17 other proteins that are very stable, which we know from SARS-1 and the N protein lasting 17 years. It never mutated. Furthermore, even if the vaccine continues to confer protection, it will likely be less robust protection, and you may be asked or required to get another vaccine series very soon. I absolutely called it exactly.
You totally nailed it.
Nailed it. And then,
yeah, I mean, I think the thing is,
and let me say one more thing. This really irks me. Fauci, Atul Gawande, who's probably a friend of yours. I've never met him.
I know him. I know him by reputation. I'm not personal friends.
Scott Gottlieb, who used to be the head of the FDA and is now on the board of Pfizer, and many medical doctors continue to say the vaccine confers better immunity than getting the disease. They all said that. I've got videos of Gottlieb saying it on Megyn Kelly's show, the lady that used to be blind, very pretty. She does a radio or a podcast.
I've been on her show a few times. Yeah.
Oh, you have? Oh my God.
Yeah.
See, this is so great. I'm I'm starstruck, but I'm amazed.
Oh, come on, Reed.
But anyway,
so Reed, I'll tell you
my point though. Let me say this. This really irks me. Gottlieb was on her show and he said, no, the vaccine confers better immunity than getting the disease. So you should get the vaccine. He's on the board of Pfizer. And he's wrong too. It does not confer better immunity than getting the disease. It goes against every tenet that we learned about human immunology. I'll tell more details later. Atul Gawande was starting a vaccine company for COVID, and I heard him say it on a radio station, and I recorded it and kept it because in case anyone challenged me on it. He said the exact same thing. And of course, Fauci said it every day on TV, that he wanted the people that had gotten the disease to get the vaccine. Okay, now those guys have major conflicts of interest. And so they're either not telling the truth or they don't understand immunology. You get much broader protection when you get a disease than a vaccine. And I've got a video now of Fauci saying exactly the same thing, even though he said exactly the opposite.
I'll tell you my thinking on January 10th, 2021. This is based on like evidence-based medicine principles. And actually, it's interesting again, like I think it reaches the same place with different reasoning. The vaccine trials had looked at as a clinical endpoint the prevention of symptomatic disease.
I have the endpoints, the primary efficacy endpoints written out for both of them.
Symptomatic
A
disease.
few slides from here.
Okay, so just real fast then, because I really do got to go home.
Yeah.
Symptomatic disease. There are two other potential endpoints that they could have done, but they didn't do that would have been interesting. One was prevention of severe disease, death or hospitalization.
Yeah.
The other was prevention of infection.
Right.
The vaccine trials were done for 3 months, 3 or 4 months. I mean, they basically they stopped the trial basically after 3 months of following the patients.
Yeah.
At that point, you have to make a decision. You can either use the vaccine for focus protection, and if it prevents severe disease or death, then you could use it for focus protection.
Yeah.
That's one use of it. In fact, I wrote an op-ed in the Wall Street Journal in December of 2020 arguing that it should be used for focus protection.
Yeah.
Use the vaccine to protect the elderly.
In other words, give it to the old people first.
Yes.
Which they tried to do in some places, which I applauded.
Yeah, but the thing is it's not just give it to the old people first. Don't think of the vaccine as getting rid of the disease.
Oh no, I know it didn't.
Herd immunity. Just think of it as a way to do focus protection. It's a way to like solve the Barrington Declaration problem of how do you do focus protection? Well, give the vaccine to the elderly.
That's one of the ways. One of the ideas, yeah. But there's many ways you can help the elderly. But go ahead.
The other possibility, like again, you have symptomatic disease prevention. That's the endpoint for 3 months.
Yeah.
The other idea is, oh well, maybe the vaccine prevents all infection.
No.
The Fauci, Birx, Walensky, she's on video saying this. They bet the other thing. They bet that it was going to prevent all infection and it was going to be long lasting.
They're completely wrong. There was a lot of reasons why you knew that it wouldn't do that.
So I looked at the trial data. I'm like, there's no way we know for certain that it's going to be long lasting protection.
Right.
The fact was that we knew that you had COVID recovery provided pretty substantial protection. So the marginal benefit of the vaccine to the COVID recovery is small. This also could help with, this is a time when the vaccine doses are in short supply. It could help with the world supply by you check to see if someone's been infected. If they have been infected, they have a clinical history of infection.
Right. You don't
then wait till later to give them the vaccine, if anything, right?
Yeah, absolutely. And the main reason is you don't need a vaccine if you've had the disease. You just don't need it. The disease will last longer.
Let me put it slightly less dogmatically. The marginal benefit from the vaccine, if your COVID recovery is smaller, much smaller than if you're immune naive. So that means you shouldn't be prioritizing them. In fact, so this ignorance about the importance of natural immunity killed people.
Yes, absolutely.
Because we gave the vaccine to people for whom the marginal benefit was small, instead of reserving the vaccine for everybody else who were immune naive, or all the vulnerable that were immune naive.
Yes, that's a very good point about the problem we had with the number of vaccines. Mine is all theoretical and it's right, but that's a very good practical reason why we should not have vaccinated people that had already had the disease and recovered.
So I think it's one of these things where like the ignorance of the science by some of the very top medical and public health people in the United States is just, and not just the United States, the World Health Organization is mind blowing. It really did result in many unnecessary deaths.
Almost more than many. We're talking about tens of millions of excess deaths, no question about it. In the long run, with the collateral damage, tens of millions.
I just can't.
It's unfathomable almost that they would not be able to. Did they not know the basic science behind any of this? Is that what happened, or did they just do it on purpose? It's got to be sort of one or the other, unless maybe their political ideology made them just not care about the truth, and the end justifies the means kind of a thing or something. I don't know. They wanted Trump out of office, I think. And so part of the problem at the beginning, a lot of people say, and I don't want to talk about politics, but a lot of people say they screwed this up to make him look bad. Of course, it didn't make him look bad. all these non-pharmaceutical interventions did not do anything. Just look at
I mean, I just don't care about the politics. What I care
I
about
don't
is
either.
the what we did is we ended up with this catastrophic failure where we had a tool that could have been used for such good. Instead, we destroyed our societies around this
Right.
vaccine.
Yes.
We had this hubris about our ability to stop the virus using these medieval methods like lockdowns that never was going to work, but was always going to cause catastrophic harm. And our entire like the top of the scientific bureaucracy embraced it and suppressed people like you from pitching in.
Right.
It's absolutely mind-boggling.
It is.
And I think the people of the world should I mean, there need to be deep reforms so that this kind of thing never happens again.
So, Jay, thank you very much again for a great discussion. And we really covered a lot of very important topics that a lot of people didn't understand as you've known the whole year. But let's meet again if you'd like to.
I'm looking forward to it, Reed. This is a lot of fun.
It sure is. And I can't wait to see you again. And we'll do it as soon as we can both get free. And I'll enjoy it very much. And I'm looking
Okay. You have a good evening or good afternoon for you. You take care.
Thanks, Jay.
Bye now.
Bye-bye. Wow, what a great person Dr. Jay Bhattacharya is. I owe him a tremendous debt of gratitude for giving us all this time to share his expertise. I wanted to make a couple announcements tonight. First, I wanted to, actually it's nighttime now. It was daytime this morning when we finished where I am. As you may have seen the light behind the shade behind me, now it's dark. It's almost 2 a.m. now. I need to get some sleep because I haven't slept in way more than 24 hours now. The reason is because Jay and I live 9 hours apart. And so timing these things is very difficult, especially for him because he's teaching classes this term and he's very busy. So I volunteer to do it through the middle of the night, which I'm happy to do. And I'm used to it as a surgeon. So it's no big deal. But the first thing I wanted to do was apologize for getting a little punchy near the end of that one. That one lasted longer than 4 hours. So I do apologize for that. Lack of sleep and intense thinking for that long will make me get like that sometimes. The other thing I wanted to talk about was a live presentation that Jay and I have been talking about doing in May from the campus at Stanford University. We want to do a Q&A session where we can answer questions as they come in, as they scroll down the side of the screen live. So please be ready for that. I'll make a lot of announcements about it, but have your questions ready and we'll do the best we can to answer them. If we don't know, we'll say we don't know. The other issue I wanted to talk about was the issue of please share these videos that we're making. I know that people can't watch the whole 10 hours. We're now over 10 hours, so we're not even halfway done yet. But I will break them down eventually into smaller pieces, maybe 10 to 12 minutes long, correctly titled, so that you can watch the things that you want to watch. But we felt it was very important to sort of cover everything in these discussions we're having. And we are finding a few places where we disagree or did not know something, for example, that I had done. I know more about Jay than he would know about what I've done on this because he's been very visible, which is great. Tremendous that he was able to do that. For me, I've had a lot of trouble with it because of shadow banning and outright removal of videos. And it's very upsetting. It's been frustrating because as we mentioned in the show today or in the discussion, because a lot of these discoveries that I made from the beginning, like the being the first person to calculate the correct infection fatality rate. And now even lowering that a little bit because the cases were also inflated. So the numerator was too high and the denominator was too low. And just fixing the denominator got me down to 0.1%, which is 1 in 1,000, which is very close to what the flu is. And if people had known that early on, if I'd been able to get the word out or get the attention of the television networks like I tried to do, most of this would have been averted, which I mentioned tonight, but it's true because people, I don't think, would have agreed to a lockdown if the infection fatality rate, if they had known that the infection fatality rate was the same as the flu. So anyway, I don't want to rehash the whole talk, but even the part about us reaching herd immunity on January 11th was something that I haven't seen anywhere else, but it's certainly true for the wild type I'm talking about. And I made a video about it. I was very happy to see that that had happened, and YouTube took it down. So I've been struggling with this with posts being taken down from Facebook and shadow banning on Facebook, and the same with the videos on YouTube. Removal of the videos and shadow banning. For example, when I had about 2,600 views on part 1 of our discussion with Jay, I was getting about 400 views a day. And I got a notice from YouTube that said we had violated a community standard of not talking about certain topics. It might have been the origin of the virus. And I spent a lot of time, if you'll remember, presenting my proof that it came from a lab to Jay. And that might have done it. But from that point on, instead of getting 400 views a day, I started getting 10 views a day. And then when I posted part 2, I only got 10 views a day the whole time it was posted. So the first month I got about 330 views or so, which is about 10 per day. So it's been a struggle, and I hope you guys will share these things. And I know you don't have time to watch all of it, except a few people have, and I appreciate that very much. Also, if you have comments or questions, please put them in the comments. I answer everyone that sends me a private message. So I will answer it either way, but if you could put it in the comments, other people will benefit by it. So please do share these. And I am going to eventually break them up into smaller pieces, like I said before, maybe 10 to 12 minutes long. So you'll be able to watch the topic that you're most interested in. Let's see, is there anything else I'm forgetting? It's getting a little late. I need to get some sleep. Let's see. I mentioned the live event. I think that's about it. So thank you very much again. And I will see you for part 4, which we'll probably record in the middle of this week or next weekend. And I think 2 more really solid sessions will get us very close to the end. We're going to try to go a little bit faster. We haven't even gone halfway yet after 10 hours. So we'll go faster and get it wrapped up. But thank you very much again for watching. And I'll see you for part 4.